really worthwhile. So it's 6:15. People are checking in, and at this time, I want to request Dr. Swapnil Kenny and his team to present to us the results of the last quiz. So as you know, IFIX 2020 is not just the conference, it's not just the lectures, but we have quiz, we have a Telegram group where we discuss cases every day. We have a daily paper where one uh, paper is presented to the audience every day only. Every day there is a paper on a topic, published paper, peer-reviewed paper, which is given to the delegates so that get into habit of reading. So there are a lot of things happening at IFIX, and Swapnil, please present to us the results of the last time. Thank you.
So we welcome all the delegates once again to one more session of IFIX. As you remember, the last weekend was all about the elbow. And we had a wonderful quiz which was designed by our faculty. Now, a few points about the quiz is that if you answer the quiz, that is the only way you can get your certificate. We've still kept the quiz open, so you can still go ahead, look at the quiz and answer it. So we will be announcing the results today. So today we have with us Dr. Gaurav Gupta and Dr. Binoti Seth, who were the faculty for the last session on elbow fractures, and they would be taking us forward with the quiz. So over to Dr. Gaurav Gupta.
Yeah. Hello everyone. I hope I'm audible to everyone.
Yes.
Yeah. So
yes, please go ahead.
So the first question was, which of the following is not used for classifying lateral condyle fractures? And 37 people have marked it wrong. Finn-Bogason classification, which is very well used to classify lateral condyle fractures, and in fact all of these are used, like Jacobs, Weiss, Finn-Bogason and Mills. So the answer was none of the above. The second question was about lateral spur. So which of the following are true about lateral spurring except? So the correct answer is C, that the age at the time of injury is not associated with the severity of spur, and this option was wrongly written as negatively associated. So around 42 people have marked it right, which is good. The third question was about the timing of removal of implants. So it does not depend on a particular time, it depends on radiological healing when we should remove the wires, and around 70% of people have marked it right. Fourth question was about the medial epicondyle fracture, and the indications of operative fixation are, all of these are indications. Incarcerated fragment is the absolute indication, whereas others are relative indications, and 96% of people have marked it right, which is very good. Fifth question was, 6-year-old child presents with an undisplaced lateral condyle fracture seen on AP and lateral view, and intra-articular extension can be confirmed by following investigations. More than one of the answers were true here. Arthrogram, yes. MRI, yes. Ultrasound, yes. Internal rotation view can give us the best displacement, but not the intra-articular extension, and it was marked wrong by 64% of people. So we should know this also. Which is the best view to assess displacement in medial epicondyle fractures? And axial view is the right answer. Around 46% of people have marked it right. This is all statements are true about lateral condyle fractures except it was a tricky one. Internal oblique is the best view. There are around 20% chances of growth arrest in displaced lateral condyle fractures. A true fact. Screw fixation has lesser incidence of delayed non-union, it's true. And screws does not increase but decrease the possibility of lateral spur formation in comparison to K-wires. And 74% of people marked it right. Good. All of these are close reduction techniques for displaced radial neck fractures. Patterson, Israeli, Augustus. Judaise is not a technique, but it classifies radial neck fractures. 66% people marked it right. This is a simpler one. Identify the injury, medial condyle fracture. 87% marked it right. And the last question was about the stability of the configurations. Classical paper by Dr. Sabharwal. Around 71 people marked it right. That is the D1. D is the correct answer. The more divergent they are, the better it is.
Now over to Dr. Binoti for the next set of questions.
Yeah, so this is based on session 4, that is on forearm, distal forearm and hand fractures. So what is the best method of treatment for this fracture in 8-year-old child? Exaggerate the deformity, traction, flexion and cast, derotation maneuver, that is pronation of forearm and cast, radius and ulnar nailing or only radius nailing. So this is a volar angulation green stick fracture. So the correct answer is B, that is you rotate, derotate and then cast. So 57% have got it right. Which of the following is true for prevention of compartment syndrome while nailing the forearm bones? Maximum 3 attempts at close nailing, maximum 10 minutes for attempting close nailing, low threshold for open reduction, or all of the above. So all of the above is the right answer, and almost 97 out of 127 have got it correct. How will you treat this fracture in a 7-year-old child? Splint immobilization, cast in situ, reduction and cast in operation theater, or reduction and cast in OPD? So this is a low energy torus fracture, and the correct answer is A, splint immobilization, and 40% have got it right. What is your further treatment on evaluation of this post-reduction X-ray of 7 years male child? Acceptable reduction, so continue same cast. Displacement not acceptable, so remanipulate and cast. Rotation not acceptable, so again remanipulate and cast. Or plan surgical treatment in the form of nailing. So as was nicely explained last week, that here if you see the radial bicipital tuberosity and the radial styloid are not at 180 degrees to each other, so it's a rotational malalignment, and that's why C is the correct answer. The most common complication of forearm shaft fracture is neurovascular injury, non-union, refracture, or elbow stiffness. So was nicely demonstrated by Rujuta in a case. So refracture is the most common, and almost 80% have got it right. Risk factors for loss of reduction in distal forearm fractures are all of the following except both bone fractures at the same level, complete displacement of radius, non-anatomical reduction, or residual volar angulation of 5 degrees. So all the others are an indication except for residual volar angulation, which remodels well. So 80D is the correct answer, and 65% have got it right. Which index best predicts the loss of reduction in cast treatment of distal forearm fractures? Whether it's cast index, 3-point index, gap index, or padding index, and almost 81% have got it right. It's the cast index. Common causes of growth arrest in distal radius fascial fractures are high energy trauma, repeated forceful attempts at close reduction, attempts of reduction after 7 to 10 days of injury, or all of the above. And I think majority have got it right. It's all of the above. 118 out of 127 have got it correct. What is the name of this fracture? Bennett's fracture, Femur fracture, extra octave fracture, or Boxer's fracture? So this is a distal phalanx fascial injury, mostly open injury with a nail bed injury. So the correct answer is Femur fracture, B, and 86% have got it right. Which of the following metacarpal fractures can be treated conservatively? Thumb metacarpal base fascial fracture, little finger metacarpal neck fracture with 20 degrees angulation, metacarpal shaft fracture with significant rotation, or metacarpal head fracture with intra-articular extension. The B is the correct answer, which is likely to remodel even if you treat conservatively. And I think majority have got it right. And the last, the books written by faculties of session 3 and 4 does not include Core Knowledge in Orthopaedics, Hand, Elbow, and Shoulder, The Door is Not Locked, Finding Happiness in the Real World, The Pediatric Upper Extremity, or Fractures of the Wrist in Children. Unfortunately, only 46 have got it right. So I think the delegates have to log in early and be present at the session where we introduce our esteemed faculty.
Thank you very much, ma'am. And that was just about what we have for the quiz. As told by Dr. Taral, this quiz is essentially an audit of what you have learned and what we have taught. So I would request all the delegates to kindly be there for all the sessions so that you can learn more and we can also understand where we need to concentrate more. So this is the end of this session and I pass on the baton to Dr. Taral.
Thanks, Swapnil, and the entire quiz team. We call it as inquisitive. This is IFIX net-based quiz, and more and more people are attempting the quiz, and the questions are getting tougher and tougher. And I want to say that the book about happiness was written by Roger Cornwall, and this way we also get to know about the other side of pediatric orthopedics. So it's 6:26 Indian Standard Time. We call it as IFIX Standard Time. IFIX has always been ahead of its time, and though 6:30 is the official starting time, already more than 100 people have joined to this webinar. So we welcome everybody. Welcome Sheetal, and let's start with today's program. So I'm going to start with introducing the faculty of this program, and uh, let's start getting. So if we get 4 minutes extra, we get 4 minutes extra of education. So let us start now. So this is the fifth session, and we have a packed program, 2 hours, 1 hour where we're going to learn. There are going to be lectures, and the second part where we are going to apply this learning through cases and discussion. So I am the session moderator. My name is Taral Nagda. I'm based in Bombay. I am one of the founder members of this organization called IFIX. And most important, when I'm not doing pediatric orthopedics, I am also an organic farmer. I have a farm near Nashik, around 180 kilometers from Bombay. I'm gadget freak. I'm webmaster of Pediatric Orthopedic Society of India. And lastly, last 5 months, I have also got a chance to improve my yoga skills and bend backwards a bit. And the man behind the mission, Sheetal Parekh, who caught on to this idea, supported us from 2014 onwards, and it's because of his efforts that we have so many speakers across the globe, contributing to this conference. Sheetal, I want you to introduce the international faculty, and then I will introduce the national.
Yeah, so I'd like to introduce first, thanks Taral, and welcome everyone to this IFIX 2020 web conference. So the international faculty is Ben Hayward from Boston. He's an assistant professor in orthopedic surgery at Harvard Medical School and associate fellowship director of Orthopedic Sports Medicine Fellowship Program. He is on the board of directors of the relative newer society, the Pediatric Research in Sports Medicine. He's a chair of the mentorship committee and a member of the QSVI trauma committee for PASNA, and a former member of the AOSSM Stop Sports Injuries Education Committee. He's interested in pediatric orthopedic trauma, sports medicine injuries, and his research interest includes pediatric ACL tears, OCD, patellar instability, glenohumeral instability, adolescent clavicle fractures, overuse injuries. And I've known Ben for a while. We have done quite a few courses together. He's also an editor of the book on pediatric femur fractures. So he's, it's correct for us to have him for this webinar so he can educate all of us. Besides pediatric orthopedics, he enjoys hiking, skiing, golf, and outdoor travel. And he's a coach to several of the children's ice hockey and lacrosse teams in that area. So welcome, Ben.
Thank you.
Our next international faculty is Dr. Uni Narayanan. He's from Toronto, Canada. He's a professor in the Department of Surgery, Division of Orthopedics and Child Health Evaluative Sciences. Works at the Hospital for Sick Children at University of Toronto. Very talented, very gifted surgeon. And I would like to welcome him to this webinar. Besides pediatric orthopedics, he's interested in outcomes research. He teaches, travels, and he enjoys tennis. So welcome, Uni.
Okay. From the Indian side, I want to welcome Alaric Arujis, who is the Vice President of Pediatric Orthopedic Society of India and medical advisor to Miracle Feet. He is a consultant at Jayabhai Wadia Children's Hospital and Ilavati Hospital. And He's a very academic at the same time, a fun-loving person, and none of our conferences are complete without Alaric contributing to it non-academically too. Jayant Sampat is from Bangalore. So Jayant is a consultant at Rainbow Children's Hospital. He used to work in UK and then decided to come back to India and has become part of the Posi gang here. And uh, Jayant is also a weekend runner. So when he's not examining people walking, he's running. He travels a lot, and he is also stand-up comedian. And his acts are to be watched for on Saturday evenings. Secret meetings which happen in one of our rooms. Sunil Vijay Singhe is a dear friend. He's a past president of Sri Lankan Orthopaedic Association. He's a pediatric orthopedic surgeon, not by choice, but by accident, because in 2009, we did a OC Potna pediatric fracture course when he was secretary of Sri Lankan Orthopaedic Association, wanted to be an arthroscopist, but ended up being a pediatric orthopedic surgeon. He works at the Children's Hospital in Sri Lanka and has a big responsibility for treating the young with orthopedic problems in Sri Lanka. So what he also does is traveling to exotic places, and I'm sure POSICON every year adds to this list. What we have in common, both of us are fond of cricket. He likes to read books and he's a wildlife enthusiast. And I want to say that his wife and his son both are also excellent wildlife photographers, and I've seen some of their photos. Swapnil is the secretary of Bombay Orthopedic Society and associate professor of JJ Hospital and GMC. Swapnil, the name means a dreamy person, so he dreams big. And as you see that he's part of SICOT and so many international societies, but a transformation which I've seen in Swapnil, it's not in only terms of his weight from 2000 to 2020, but also in terms of the maturity and responsibilities he's taken care of. Not many of us in the audience know that he is also a watch connoisseur. So he's the man to watch for. And he has done, apart from a lot of courses and workshops, he's done a course in mechanical watchmaking. And probably this would interest Dr. Chandak a lot. Sukalyan is a pediatric orthopedic surgeon from the Northeast. He's the only pediatric orthopedic surgeon to the 7 states which are in the Northeast. He was trained in Bombay with us and then went to Cincinnati for a short fellowship. And Cincinnati, and he's a very soft-spoken person, interested in fitness. And I'm surprised to know he loves to work with gadgets. So welcome, Sukalyan, to this edition of iFix. Kailash Sharthi from Chennai, the land of idlis and dosas. He's attached to Kanchi Children's Hospital. What is surprising is that he likes 2 B's and a D. So badminton and a bike. You can see a Royal Enfield bike which he owns in that picture, and he also loves to dance. So with this, we go live at iFix. We have 2 sessions, one where we will learn, and second session is to discuss and see cases. So for the first session, I invite Ben. Ben, please share your screen and start your talk.
Okay, I will share my screen. Thank you so much to the faculty and to Sheetal for this invitation. It's a real honor to be with this group and be discussing these wonderful topics. So we'll start by talking about femoral shaft fractures in younger children, those under 6 essentially. So the outline for this session, which will be about 15 minutes, will be covering neonatal femur fractures, mostly treated with Pavlik harness, but other techniques are accepted. The femoral shaft fractures in infants and toddlers, essentially 6 months to 2 years or so. And the standard of care is really spica casting, but again, other techniques are acceptable in certain situations. And then we'll take some time and discuss child abuse and non-accidental trauma briefly because of the importance for this age group. Finally, we'll talk about femoral shaft fractures in preschool and younger school-age children, where spica casting and occasionally elastic nailing and other techniques are utilized. So let's start with a neonatal and perinatal femur fractures. And the mechanism of injury is most commonly obstetric injury, secondary to excessive traction or torque during a difficult delivery. Breech presentation is a risk factor. And then osteogenesis imperfecta is a diagnosis to always be aware of and be mindful of if there is a fracture of this kind or multiple fractures in particular. And then a non-accidental trauma in newborns who have gone home and child abuse is important to remember. So the unique features of this age group when we think about femur fracture healing is really the rapid healing potential. So fracture stability can be obtained within days rather than weeks. And then healing can be completed within weeks rather than months compared to our older kids. The long-term outcomes are generally excellent, and the treatment is almost always non-surgical, though occasional exceptions arise. So in terms of obstetric fractures, these can occur in a normal child in a normal delivery, but as we mentioned, breech positioning is more common. And then historically, it was felt that vaginal deliveries were much more common than C-sections, though the rise of C-sections in the last decade or two has suggested in some studies that there are as many femur fractures with difficult C-section deliveries as with vaginal or abdominal delivery. So the incidence has been not well calculated, but one study suggested less than 1 per 1,000 live births, really 0.1 per 1,000 live births from a single hospital in Ireland, and then higher in the very low birth weight audience. So there are no prospective studies or methodologically rigorous studies on this of which I am aware, and an opportunity for good research. So again, the risk factors, prematurity and very low birth weight. So that would include twins, and then also very large birth weight babies who are associated with difficult deliveries. Osteogenesis imperfecta and other metabolic bone disorders such as neonatal rickets, and then prolonged delivery or a small uterine incision in the case of a C-section. In terms of where these obstetric fractures occur in the femur, most commonly are shaft, though all locations have been reported in case reports. And in terms of the neonatal anatomy, an important thing to know is that the head, neck, greater and lesser trochanter represents essentially a single segment of the femur and can separate as a unit from the proximal femoral shaft. In terms of the presentation, when we get called to the wards, we're usually assessing a case of pseudoparalysis, i.e. a child's unwillingness to move the extremity. Here's a nice diagram from a Springer textbook by Randy Loader and others showing this child's right leg not moving despite active movement in different positions with his left leg. So swelling and tenderness can be detected. And so simple radiographs essentially diagnose this, though physeal fractures can be missed. So sometimes there's a role for ultrasound or rarely MRI. So if we think of femoral shaft fractures along an age-based algorithm, this is sort of a gross breakdown. Our basic treatment guidelines, we tend to have 0 to 6 months get treated with a Pavlik harness. We'll talk further about these other age groups, but 6 months to 5 years, most commonly spica casting, 5 to 11 years flexible IM nails. And Uni will talk to us about that and the variety of other treatments that are possible. And then I'll return to discussing the older pre-adolescent and adolescents. And the standard would be IM nailing, but there are many exceptions and options for this age group. So if our neonatal femur fractures, those under 6 months, the treatment most commonly is Pavlik harness, but right around the time of birth, especially for the low birth weight babies, sometimes a simple splint can do, and even a tongue depressor in a small child wrapped in Rebbril can serve as a nice splint, stabilizing the fracture while still protecting, against the challenges with the family of the Pavlik harness. Here's a diagram of a standard Pavlik harness. Holding the child's leg in abduction and some external rotation and flexion. and that usually reduces the fracture with a good orientation. So when we talk about the femoral shaft fractures in those 6 months to 2 years or so, infants and toddlers, we're usually talking about spica casting, though in that 6 to 9 month group, you might have a role for a Pavlik harness. The mechanisms of injury tend to be accidental trauma and falls, a fall from height, fall downstairs. These children are starting to walk and move and can get themselves into all kinds of trouble. And then a not uncommon mechanism would be a fall by a caregiver carrying a child. Importantly, non-accidental trauma needs to be remembered for any child who is not of walking age. So especially these younger infants. In terms of the epidemiology of this group, different studies have suggested around 20 to 25 per 100,000. And then femur fractures are about 11% of all fractures in kids under 2 years old. We tend to see this bimodal peak, 3 months and then 30 months in this younger age group. And males tend to be more than females, especially with the older ages within this group. So even males in the infant years and the toddler years seem to get themselves into more trouble than females. So in terms of the location in this age group, the shaft is 65 to 70%. The distal metaphysis we can see, so here's a typical femoral shaft fracture, but the distal metaphysis might be injured more commonly with a fall or with a caregiver carrying a child, as that leg may be protruding from around the torso of the falling adult. And then proximal distal epiphysis or physis is much more rare and tends to be associated with higher energy injuries. So when we talk about spica casting for this age group, there's some principles to adhere to. Of course, traction is of great historical interest, and while it may have fallen out of relative favor in the US due to risks such as compartment syndrome, pin tract infections, cost, and really patient satisfaction and the need for inpatient stays, which we've discovered are unnecessary, there's still a role for traction in various situations. So spica casting may be the gold standard, and Uni has some terrific principles to share in his talk about spica casting for the younger subset of the middle age group that he's covering. But here you can see essentially flexion at the hip, flexion at the knee, and some degree of abduction. There's some debate about the exact perfect location, but generally we sort of think 70 to 90 for those two, and 20 to 40 of abduction. So you can see a standard femur fracture here, treated with a spica cast, just a touch of mold here in the valgus position. And that's a thoughtful maneuver based on the idea that these tend to drift into varus. So you want to mold your spica cast with some anticipation of potential displacement. And then we see sagging in the sagittal plane on the lateral, both posteriorly and displacement anteriorly. So we see both recurvatum and procurvatum. And so your injury films should be studied and your positioning should be studied to make sure that you apply the right amount of pressure. So getting into child abuse and non-accidental trauma, this would be the older neonatal group, the infants and the toddlers. So at home, if the child has gone home and it's not thought to be an obstetric fracture, but they're of non-walking age, really we think of it as non-accidental trauma until proven otherwise. Some studies have suggested up to 60 to 90% of cases in these non-walking age younger children may be non-accidental trauma. Femur fracture by some studies is suggested as the most common long bone affected in non-accidental trauma. And the diagnosis really can be life-saving in that most fatalities that have been studied that's associated with non-accidental trauma have some history of prior medical visits. So this is important for us as orthopedic surgeons to really step up our game and become complete doctors, not just bone doctors, but situational doctors, and involve a larger team if this is a possibility. The femoral shaft is more common than other locations, though the metaphyseal or corner fracture must be remembered. And then here's our differential. So in the textbook that was alluded to before, for which I owe a ton of credit to Dr. Daniel Hedequist. So Dan is my partner and one of my mentors, and we did this, edited this textbook together. We have a table on the differential diagnosis. So of course, accidental injury is possible, birth trauma, osteogenesis imperfecta, rickets and Caffey disease, congenital syphilis, leukemia, and then rarer things such as congenital insensitivity to pain and coagulation disorders, and then normal radiographic variants. But as I say, a non-walking age child with a femur fracture really should be thought of as child abuse until proven otherwise. And then the risk factors are important to know about. So a suspicious or inconsistent story or delay in presentation, implausible mechanism of injury, multiple trips to the emergency room. It has been shown to be associated with lower socioeconomic status. Single parent households or live-in non-parent partner have higher rates of this. Fractures that are seen in multiple stages of healing. And then other fractures are typical of non-accidental trauma, such as posterior rib fractures, corner fractures, as you see here, metaphyseal corner fracture. Scapula fractures are rare for other reasons, spinous process injuries and skull fractures. So there are other associated injuries as well. Bruises, so bruises that are not in the limbs, but instead in the head and neck region or the back region, and in the genital region, burns, retinal hemorrhage, subdural hematoma, and then visceral injuries. So all of these should be in the back of our minds as orthopedic surgeons so that we can involve a larger team in thinking about this. So this is really a multidisciplinary or team approach. And most hospitals have a child protection service, or especially at pediatric hospitals, something similar. The orthopedic surgery team is important, but must work with the radiology team in the skeletal survey, which is a key to the workup for non-accidental trauma. So this is an AP of all parts of the four extremities, and then an AP and lateral of the spine and skull. So the radiologists and orthopedic surgeons each need to individually review these and make sure there are not multiple fractures or fractures in different stages of healing. And then social work should be involved and other services as indicated. Moving on to the femoral shaft fractures in preschool children and younger school-age children, really our standard is still spica casting, though emerging evidence suggests that maybe elastic or titanium intramedullary nails may be appropriate for the older subset in this group. So our mechanisms of injury in this group would be accidental traumas or falls from height downstairs. Bicycles and scooters are now in play. And then motor vehicle accidents are rare, but we see this in higher energy scenarios. And then this is a little young for the sports-related trauma, but we're seeing kids be engaged in huge amounts of sports at younger and younger ages, you know, in the US and around the world. And so you can have collisions or sport-related injuries, such as a twisting injury with a young skier. In terms of classification, the AO has a thoughtful classification, which has good research purposes. But for the most part, around the world, we tend to use the descriptive classification. And the important aspects are open versus closed. The pattern of the fracture is a transverse, oblique, or spiral, short oblique, long oblique. Is there comminution? Segmental fractures are rare and associated with higher energy injuries. And is there shortening? And what is the shortening in centimeters? And what is the angulation in various planes in degrees? Of course, rotational malalignment is also important. So our standard diagnostic workup is AP and lateral x-rays, and we need to make sure we see all segments of the bone. Concomitant injuries, certainly with higher energy mechanisms, are important because of the distracting pain with femur fracture. So a secondary survey is key. And then general surgery or trauma service if it's a higher energy issue. So Other fractures in the same bone are pretty exceedingly rare in this group, but have been reported. So that's why we want to make sure we see all parts of the bone. So our standard treatment for this group is a spica cast. There's emerging evidence that for some kids, a single leg spica cast may be appropriate, i.e. a walking spica, but the standard still tends to be a 1.5 leg or a double leg spica. Exceptions for use of a spica would be an open fracture at times, neurovascular injury, multiple fractures or polytrauma, a severely length unstable fracture, and then a heavier child in the older ages, such as 4, 5, and 6. In those children, elastic intramedullary nails maybe have certain advantages, such as more stability, allowing for earlier mobilization and less strain on a family. And so a nice study by Eric Gordon and the group from St. Louis has suggested even as young as 4 years old, this may be appropriate. The disadvantages, of course, relative to spica casting are it's an invasive procedure, requires some technical expertise or experience, and often requires a secondary surgery in the form of removing the hardware, particularly in this younger age group. And there are, of course, some complications. Other contraindications for a spica cast might be skin issues if there are severe abrasions, severe shortening. The principles that'll be reviewed again, and Dr. Sheetal Parikh has a wonderful ViewMedi video on application of a spica cast that I believe we need to provide a link for. It needs to have adequate stability, so whether we use plaster or fiberglass, generally struts in the right positions need to be applied, and then cast molding is important to counter the displacement as we discussed before. So it tends to displace into vera, so a valgus mold. I've seen more displacement with procurvatum with the weight of the distal aspect of the distal fragment leading to procurvatum, so tend to apply an anterior mold, though we see the opposite as well. And then external rotation tends to be the position of displacement, so applying a little bit of rotational internal rotation during the molding process is important. Importantly, spica casting can be quite forgiving, and so the parameters are of acceptable alignment, have a nice range. So you can see here, here's displacement, like we talked about in the varus position and in procurvatum. And this was allowed to remodel, and the child's doing terrifically well here just 2 years after just 6 months after the fracture. Complications of spica casting includes skin issues. There can be frequent soiling, so you want to be thoughtful about use of a Gore-Tex lining or other measures so that the family understands cast care. And then rashes, pressure wounds, ulcers, so adequate padding in the key spots is important. Here's another example of a child who had an obstetric fracture with a significant anterior bow. This displaced, and so spica casting was applied, and this remodeled nicely. So you can see how a spica cast can attend to what looks like a very tricky fracture. And then as we talked about, the older kids may be acceptable for elastic intramedullary nailing. And Uni will discuss further some of the complications, but briefly, nail prominence, soft tissue irritation, malunion, because you don't necessarily have rotational control. Angular malunion can happen. Leg length discrepancies, less common, but common in length unstable fractures. And then refracture can happen after nail removal. So again, this covers the 0 to 6 month age group, and then the 6 month to 5 year age group with kind of our two standards of Pavlik harness, though splinting is acceptable for the very young child, and then spica casting, though elastic nails may be acceptable for the older child within this group. Thank you very much.
Ben, wonderful talk. There are some questions, some of them will take at end of these sessions, but the one question which is very common and people have asked this is, what is the youngest child you will give a spica, and what is the oldest child you will give a spica?
Yeah, so I think those parameters are helpful, though they're not black and white rigid guidelines. So I tend not to go well below 6 months for a spica, though a larger 4 or 5 month old child may be acceptable for a spica. And then the oldest, we've certainly seen spicas effectively used in the 6 to 12-year-old age group historically. But these days, not going much above 6 or 7, it would have to be a much lighter or smaller child. And then certainly there are kids with various syndromes or medical conditions that make them almost more of a 4-year-old despite being 7, for example. So I would say 5 months up to 6 to 7 years for a spica, but we've certainly drifted younger with our elastic nailing compared to spica in that school-age child.
Hey, Ben, it was a great talk. Thanks for that overview. I had a couple of questions. One is that have you seen any complications of Paulic harness? Like we discussed complications of spica. Anything that you need to watch in that very young neonate about complications? There were talk about possible femoral nerve palsy with flexion of the hip, and have you seen any issues or have you encountered any complications?
Absolutely, that's an important point. We've certainly seen that in association with Pavlik harness use for DDH, developmental dysplasia of the hip, or congenital dysplasia of the hip, and therefore similar principles apply. I think the Pavlik harness with the femur fracture, because we're using it in a young age where healing is quite abundant and sort of occurs readily, there's a little bit less vigilance with the exact position of the Pavlik harness. Therefore, I think 70 to 90 is acceptable for your hip flexion. And it may be more important to be positioned closer to 90 with DDH. And it's the higher flexion rates or degrees that we've seen those femoral nerve palsies with. So I haven't personally seen it, but it's reported. And so I think making sure you don't overflex the hip for the sake of the femoral nerve is important. And then of course, Pavlik harness, other complications, can be skin breakdown in a young child from the straps, particularly those Velcro straps can have kind of sharp edges. So you need to be mindful about the padding and the position of the straps and the fit.
That's an important point. Our technicians, they always, pad the market as well as pad them properly so that it's very fragile skin in that area, and important to make sure you don't get any skin issues as well. And one second question before we move on to the next talk, and we'll have plenty of time after the talks to go over questions while we discuss the cases. But one other thing about non-accidental trauma and trying to differentiate it from osteogenesis imperfecta, do you or how frequently do you send these kids for a genetic evaluation when you're working up for non-accidental trauma, or any other tips to differentiate, from OI?
Yes, so part of our routine workup involves a lab panel looking at the metabolic bone profile of a child. So we won't necessarily call in the geneticists, right away, but the metabolic bone profile to look at the metabolic bone health of the child and potentially, other signs of OI. So there can be other causes other than OI that can be detected by the lab profile, and then the other blue sclera and other signs of OI need to be investigated.
Excellent. Darryl, should we move on to the next talk, or do you have any questions that need to be answered?
No, we can move on to the next talk. So Undi, please share your screen and you can start.
So while I share my screen, I just want to thank Sheetal, Taral, and the rest of the IFICS group for inviting me to be part of this. I think it's an incredible effort, and it's a real privilege to be involved. So I hope everyone is safe and well around the world. It's Toronto and in Boston as well. I don't know if you can hear.
Yeah, we can see your screen and hear
Is
you
that
well.
true?
Absolutely. Perfect.
Okay.
We can't see your screen now. You'll have to reshare it.
I think he needs to restart. I think
Yeah,
we lost the
Yeah,
internet connection somehow.
Can
Tony,
you
are you
see me
there?
now?
Yes.
I'm here. Can you hear me?
Yeah.
Okay, great. Well, let me get
Okay.
started. I don't know. I got a message saying Zoom had quit unexpectedly. So,
Okay.
so I'm going to speak about children's between 5 and 11 years of age. So this is beyond the preschool, but before the high school age group. So I'm involved with a colleague in Germany in a prospective pediatric femur fracture registry. This is a pilot registry. We've recruited 300 patients over 1 year in 14 centers in Europe and North America. So there's about 4 or 5 countries involved. And just to give you a sense of, it looks like most of the action is really in the preschool age group. The highest age group that was represented, this is not population-based, so it's not accurate, but most kids were in the 1 to 3 year age group. But the next largest group were in the combined 5 to 11 years of age, and you can see the distribution between boys in yellow and girls in blue, and that ratio persists across all age groups. So we're following these children up to 24 months if there are problems beyond the 12 months of age with patient report outcome measures, radiographs, and photographs. And just to give you a sense of how these fractures are being treated, under 5, the bulk of them are being treated by immediate spica casts with elastic nails being done in some of the younger children. But between 5 and 11, this column in the parts of the bars in gray represent the elastic intramedullary nailing, and that is about 40% of the treatment across all ages. That's where we really should be focusing on. There is a role for immediate spica casting. Ben did a very nice job of talking about in the younger age group, and there are really no hard and fast rules about when you should stop. Some of the principles are weight, so 30 or 40 kilograms when it starts to become a little bit more uncomfortable to transport these children. Clearly, open fractures and polytrauma are not good indications. So there is indeed a randomized trial looking at immediate spica casting versus external fixation, one of the first randomized trials done in pediatric orthopedics that was published in The Lancet in early 2000, just before elastic nails started to become very popular. And I'll mention that briefly, but these are the general principles. You can use this in our setting. We prefer to use a single spica, which allows the kids to mobilize quite early. The posterolateral thigh mold, I think Ben talked about as well. We like to keep our knee and hip flex sufficient to allow them to sit in a stroller, and this flexion allows the some stability to axial compression, so it prevents shortening or telescoping of the fracture because of that flexion, and allows you to keep the foot free. We check an X-ray in about 7 to 10 days, where we can wedge if necessary, but if a well-applied cast makes that very rarely necessary. And then the duration of the cast can be as little as 4 weeks for someone about up to 5 years of age, and we may go up to 6 weeks. If you have any concerns, what we do is we bivalve the cast, get the x-ray, and if we're uncomfortable about the maturity of the healing, we can always put them back in the bivalve cast and wrap it up for another week or two. But again, 4 to 6 weeks is usually enough. The advantages of an immediate spica cast, even in this age group, going up to 6 or 7, is, it's minimally invasive. There's no scars, there's really no risk of infection. You can make adjustments along the way, and you're not burning any bridges. If things slip and it's no longer acceptable, you can revert to plan B, which could be an operation. It's relatively inexpensive. And with what we've understood with these casts applied properly is that children can actually be mobilized. They can crawl quite early. They can even walk. The disadvantages, I think, are quite clear. There clearly is a higher rate of loss of reduction and shortening. And it becomes an issue of patient tolerance. And that's influenced by how big the child is, how heavy the child is, the age of the child, what the weather is like at any given time or any given location. They can be easily soiled and you can't bathe the child during that time. There's difficulties with mobility and transportation, attending school. Some schools may not take children in spica casts. And of course, there's reliance on caregivers who have to take time off from work to look after a child if both parents are working, for example. And it's clearly not suitable in polytrauma. This has been well studied, and I think the impacts are well understood. So this was the randomized trial I was talking about that was published in 2005. And I'll just bring to your attention that if you look at the actual outcomes comparing immediate spica cast, which is this group right here, to external fixation, in the primary outcome, the rate of malunions was 45% in the hip spica group compared to 16% in the external fixation group. But in every other dimension, including patient satisfaction and return to function, they were identical. Now, I've had the opportunity. This was a multi-center trial in New Zealand, Australia, the US, and Canada, run by Jim Wright, that completed in 1999. So before elastic nails became very popular. And I've had a chance to review these results. And those malunions that were reported, none of them were of clinical significance. All of them, none of them required corrective osteotomies. All of them remodeled perfectly fine. And we can talk in the discussion about how we define malunions. And I think that will be an important point to debate. I realize whenever I mark this, it stops me from sharing, from advancing my slides. So.
Just click on the slide again, sir.
Yeah, okay. So this is, again, the malunion rates were similar for the younger age group as well as for the older age group. So casts have been used up to 10 years of age in this randomized trial. And if you ignore the radiographic definition of malunion and accept that they did functionally very well without any physical bad appearance to the leg, with good length and a good function, then you could say that they're even acceptable. Elastic stable intramedullary nailing is really the mainstay for this group, popularized by Meadozoe and his group in Nancy. We need to distinguish flexible nailing from elastic nailing. So there are many kinds of flexible nailing systems. Elastic nailing is one principle or one particular kind of flexible nailing. Not all flexible nails are elastic. The advantages are small incisions, very little or no soft tissue dissection, early mobilization, short hospital stay. The disadvantages are they're relatively expensive. There's a learning curve, especially about understanding the principles that are greatly misunderstood. And the question is, do these routinely need removal, which would be a second operation, which is of course inconvenient. And it may not be suitable for very comminuted fractures. So the principles are important to really understand. You're putting a straight rod, which is pre-bent into a C shape, and you're forcing that C-shaped rod into a straight, narrow canal, which then forces it into a straighter position. Because of its elasticity, that rod wants to go back to its pre-bent resting state. If you put a second rod of similar diameter and similar radius of curvature, it also has 3 points of contact. It counteracts the forces of one rod in the opposite direction, resulting in this notion of elastic stability, where you actually have got 6 points of contact to balance each other off. Okay. Now, are these stable? So this is the concept of elastic stability. If you then apply an external angular force to the system, one rod will straighten out, which it doesn't like. The other rod is going to bend to its resting state, which it likes. But the straight rod wants, because of its elasticity, wants to go back to its pre-bend state. And if you let go of that external force, it will spring back into its straight state. This is true both in the coronal and the sagittal plane. The same thing holds true for translation. If you translate those segments, the rod, because of its elasticity, will spring back. What is frequently misunderstood is rotational stability. This is not a stacking system. Elastic nails, if done properly, are rotationally stable. Because they've got points of contact at the upper and lower end, if you twist the system, due to elasticity, they will spring back into their baseline state. Now, of course, if you have an external force that exceeds the elastic limit of those nails, they will plastically deform. So clearly, there is a certain limit to how much stability this has. Where elastic nails are not so good are in axial compression. So if this is a transverse or short oblique fracture, it works very well. In very comminuted or length unstable fractures, because these rods have exit points here, the fractures can shorten and these rods can slip out distally as the fracture migrates proximally. Under those circumstances, you have to think of other techniques or other ways to minimize the risk of this happening. So here's an example of a comminuted fracture where that is exactly what happened. It slid, and what was of normal length here, you can see that the rods are slipped outwards as the fracture has migrated proximally. So the ideal indications are this particular age group with a canal size of less than 10 millimeters, perhaps up to 50 kilograms, although in our study that we've looked at in adolescents up to 80 kilograms, we had no relationship between weight and elastic nailing if the technique was done well. It was other factors that contributed to loss of reduction, like comminution and so on. Mid-diaphyseal femur fractures are ideal, transverse and short oblique with minimal comminution. So let's look at some case examples of some ideal indications. So here's a 6-year-old hit by a car with bilateral femur fractures. If this was unilateral, you could consider an immediate spica cast, but bilaterally, I think elastic nails have huge advantages. And this is a good example of that. There are some technical considerations that can help minimize the risk of complications in addition to allowing you to facilitate the ease of the technique. You can use a fracture table, and I prefer a regular radiolucent table. It's important to elevate the ipsilateral side, and we do that by putting a bump under the ipsilateral flank and the buttock. It not only keeps the leg in neutral rotation, so that it's not falling into external rotation, but it also elevates the proximal femur, including the hip, compared to the contralateral side, so that you can get good imaging of the entire femur, even in the cross-stable lateral views. And this is our setup that you can see right here. Our incisions are centered over the physis, not proximal, even though the entry point is proximal to the physis. Because we're coming from distally, the actual incision is lower down, centered over the physis. Medeso, talked about doing this percutaneously or going to the muscle. We know that the most common complication associated with elastic nailing is irritation at the insertion site. And you can imagine if these rods are going through that muscle and sticking out of the bone, that's going to interfere with the range of motion and cause quite a bit of discomfort. If you spend an extra 3 or 4 minutes, you can expose the muscle on the medial side, and on the lateral side, you don't even come across the vastus lateralis. A subvastus approach takes an extra minute that allows you easy access to the supracondylar extraperiosteal surface of the bone, so that you don't have to damage the muscle at all. But this is a mini open technique. The selection of the nails, you want to get a matched pair. to occupy about 80 to 90% of the canal. A safe bet is about 40% of the diameter of the intermedullary canal at the narrowest point, at the isthmus. So for each nail. So, and you want to make sure that they are matched. Here's a technique to help for fracture reduction. If you bend these rods enough, and you do have to bend them quite significantly, so at the level of the fracture site, you can see that's about 3 to 4 times the diameter of the intermedullary diameter at the level of the fracture site. That's the extent of the bow to get that elastic stability. There is sufficient friction between that bent rod and the endosteal surface that you could use your handles to pull this leg into traction and align the fracture into varus or valgus, internal or external rotation, and certainly out to length. You can put a bump under the fracture to prevent that sag and flex over it to ensure that the sagittal plane is aligned as well. So here's an example. Here's about 3 or 4 centimeters of shortening. Here intraoperatively, we're putting that traction as I demonstrated. I can pull it out to length, and then you can advance the nails across into the proximal segment. So you are striking the nails more strongly than you're pulling on these rods, and that allows you to advance the nails across. So here's another example of that reduction technique. Here it's pulled out to length. You don't have to be perfectly matched. You can use the shape and the contour of the rod when you get to the fracture site to turn it around to enter the proximal segment and advance it across, and then you bring it back to its baseline to achieve the reduction you want. So the most frequently reported complication, I've already given that to you. It's pain or prominence at the insertion site. So how do we minimize that? Do not bend the distal ends of the nail or leave them prominent. Although that was recommended as a way to achieve some stability, it becomes a self-fulfilling prophecy. If you are doing this in order to make it easier to remove the nails, yes, it will be easier to remove the nails, but then you will be forced to remove the nails, and sometimes prematurely. Instead, we've got these taps that are beveled or not that allow you to advance the nails up into the supracondylar flare, and I like to keep them inside of the prominence of the medial and lateral epicondyles and sort of proximal to the physis so they don't irritate the skin. Loss of reduction and or malunion are, in a multivariate analysis, related to use of mismatched nails. There's a 20-time increased likelihood that you would get a loss of reduction if you use mismatched nails. If you use it in comminuted or length unstable fractures, a 5-time increase, and in the context of multiple injuries. So the errors come from errors of application, errors of incorrect selection, and errors of final positioning. So we'll go through some of these very quickly as examples. So if you use unequal nail diameters, you can understand by using the principles of elasticity that the stronger nail is going to bend and overpower the less strong nail. Okay, here's an example of that. Intraoperatively on post-op day number 1, it looked fine, but here the lateral rod, which was 0.51 millimeter greater than the medial rod, overpowered that and resulted in a valgus alignment. So do not use nails of unequal diameter. Do not use nails of unequal bending, same principles. Avoid unequal bending. Here's a case of a 10-year or almost 11-year-old girl with a nail diameter of 3.5 millimeters times 2 from a canal size of 9 millimeters. So what do you think? You don't have time to really answer this in a poll, but you can ask yourself, do you think that that's optimal? Would you accept that? Why is this suboptimal? Well, it's not following the principles. You can see that the tops of the rods are both oriented medially, so there isn't a balanced configuration. So it could potentially, displace into a more varus position. Now, you may get away with it very frequently because you've got a big thigh with lots of muscles to protect you, but in the heavier child or the older child, departing from the principles of elastic stable fixation will lead to complications. So try and avoid these technical errors. In this case, they reoriented this in the correct way, and you can see how that corrected the alignment. Lesson number 5, avoid twisting nails. So this corkscrew phenomenon, all principles of elastic stability are thrown out of the window, and you have no way to predict how this is going to heal. Those vectors are unpredictable, and you can get all kinds of displacement. Here is an example of an 8-year-old girl, 26 kilograms, treated with elastic nails. The medullary canal is 10 millimeters diameter. They use 3 millimeter nails. Is that adequate? Well, it's suboptimal because you only get a 60% fill of the canal. Using undersized nails can result in a weaker fixation, so it doesn't take much of an external force to exceed the elastic limit of these thinner nails, and you can get this kind of angulation, which we corrected by putting in a larger, more appropriate sized nails. Okay. Use with caution in comminuted fractures that are length unstable. There are other ways to treat these fractures, but if you are a fan of elastic nailing and are comfortable and have sufficient experience with this, then you can use elastic nails under these circumstances. You may consider external immobilization, like a knee immobilizer or even an external fixator. A knee immobilizer doesn't immobilize the fracture, it just immobilizes the limb in general to avoid excessive hip and knee flexion, and that may be sufficient. But now we've got these end caps that contribute significantly to length stability in these circumstances. And here's an example where the end caps can prevent these fractures from migrating proximally despite that extensive comminution. However, you have plating systems, minimally invasive, MEPO techniques, or rigid IM nails that can be done even in younger children instead of elastic nailing. Lesson 8, intraoperative imaging of the entire femur is important. Here's an example of an AP X-ray that looks comforting, but you can see the overlap with the cortex here. The lateral view shows that the nail is outside the bone. This child presented at 10 days with a foot drop due to sciatic nerve palsy. This can be avoided by making sure this technique where you can look at the ipsilateral hip in a cross-table lateral view to make sure you can see that your nails proximally are within the femur. Finally, do we routinely have to remove these nails? I think in children under 9, because of growth, the rods are going to end up being much more proximal to where you inserted them. And even if you follow those principles of keeping them flush along with the supracondylar flare, as the bone remodels and the canal narrows, they become prominent and become irritating. So I would say under 9 years of age, especially in a boy, and maybe under 8 in a girl, I would consider removing them at about a year. Some final examples. Here's a 5-year-old boy who fell off a slide with a long spiral fracture. You could treat this with immediate spica cast. You could treat it with elastic nails. It's a matter of preference. This was treated in a spica cast, but then it displaced. It shortened. It went into significant varus. But now there is early callus that's bridging across it. How are you going to manage this? In this case, elastic nails were not used because you've got some callus. It would be very difficult to reduce the fracture under those circumstances, but an external fixator could be used. So in fact, we've got lots of options for these fractures, everything from immediate spica cast, skeletal traction temporarily and switching to a spica cast after a couple of weeks, or treatment until union in skeletal traction, external fixators, plating, flexible intramedullary nailing, and of course, rigid IM nailing in the older part of this age group. It's nice to have these options because under different circumstances, they may have different advantages, and no single technique is universally applicable to all femur fractures. What influences us are certainly the age of the child, the location, personality of the fracture, the presence of other injuries. There are clearly regional practice and variations in standards of care. There are institutional preferences, and there are surgeon preferences that are influenced by their training and their experience. And I have to say that most of these treatments can be made to work with successful outcomes, and it's nice to have many of these choices. The perfect method, or the optimal method, should ensure adequate stability, should ideally be associated with early mobility, maximizes comfort, minimizes caregiving burden, minimal scarring, avoids serious complications, does not burn bridges, so always have a backup plan, can avoid secondary procedures, and be cost effective. And I dare say none of our techniques can achieve all of those in every circumstance. Don't forget to incorporate patient preferences. With 2 identical fractures, 2 different families may make 2 different choices. So some might prefer a spica cast, and others may prefer elastic nailing. And I think it's nice, for example, to be able to provide those pros and cons so that the right choice can be made for individual patients, while we wait for evidence from comparative trials that actually use patient-reported outcome measures, not only for radiographic outcomes, which I think ultimately do very well with most of these techniques, but also about the patient experience of how the experience was from beginning to end, because that may be where the big differences lie. So thank you for your attention. I look forward to answering any questions.
Thanks, Lee. That was a great talk. Very nice overview of elastic nailing. I think we have Dr. Strongo as well on the panel. I would just ask one question that I had. There was a report about more malunions using titanium nails for lower extremity fractures. At our institution, there is, half of the surgeons are using stainless steel for femur fractures to avoid the malunion. Do you think it's more about the material? Like, do you have any preference or any thoughts on stainless steel versus titanium?
I do. So I think that titanium nails provide the kind of optimal elasticity, which stainless steel are stronger and stiffer, but they are not as elastic. So whatever system you use, you really need to understand the principles. And I think every study that has looked at elastic nailing, including the complications, including the studies that we have reported, have failed to do one thing, and have failed to actually evaluate what the technique, how well the technique was done, just by looking at the radiographs, where those principles are followed. We've looked at matched nails, we've looked at, comminution, other factors, etc., but we've not actually looked at the configuration of the nails. And I think if we did that, we might find that that's where a lot of the explanation for these loss of reductions and malunions might be. A single study that looks at the results in one setting, etc., I think may be true for that particular setting. If you look at the bigger picture, I think those of us who use titanium rods around the world, who collectively have a big experience, do not share that view that there's a high rate of malunions with elastic nailing. But I think that comes from, I think it speaks to the experience that comes from applying the principles correctly, which is why I spent some time emphasizing those principles.
Very nice. And do you have any tips for nailing very proximal and distal fractures with elastic nailing, like subtroch fractures? Would you do anything differently? And same with supracondylar or a little bit lower down, distal third fractures? Any tips you manage?
I do. Could I share my screen very briefly for that question?
Yeah, only you can do that.
Okay. So here's some proximal fractures, okay? And in this case, it's actually an older child. He's about 13. Now, proximal fractures are actually very well managed with elastic nailing, but you have to alter the technique slightly. Most of these fractures, the plane of the fracture is actually in the coronal plane. In other words, the fracture is on the medial and lateral walls. So the intact part of the fracture is the anterior part of the shaft and of the proximal fragment, and the posterior part of the shaft of the distal fragment. So you can take advantage of that and advance the nails much more proximally. Because there's femoral anteversion, you want to make sure that your medial rod is directed more anteriorly so that it follows and can go much more into the neck. And correspondingly, to follow the principles of elastic nailing, your lateral rod should be directed more posteriorly into the base of the greater trochanter. So when that happens, your maximum spread is actually going to be in the sagittal plane, which is where you want it to be, so that the rods are up against the shaft anteriorly and posteriorly. So this is a lateral view, and you can see it's on the lateral view you see the maximum bend going up into the femoral neck on the medial rod, and the lateral rod going to the base of the greater trochanter. That provides you with great stability. So on your AP view, you shouldn't see the maximal contour of a rod here. It should be seen more on the lateral view. So here's an example of that. You can see that the plane of the fracture is really in the coronal plane. So on the lateral X-ray, you can see if you put your rods in the conventional way, there's nothing for the rods to push against on the medial and lateral side because that's where the fracture is. So this is how you can actually use elastic nails, not with proximal introductions, but with the standard retrograde technique, but using this principle. Here's another example, even with lots of comminution that allows you to get even, into the subtrochanteric area. Here's a subtrochanteric fracture, which follows that same particular principle. Now, as far as distal fractures are concerned, here, these are the fractures that are the hardest to treat with elastic nailing. Because of the supracondylar flare, which makes that metaphysis very wide, you have to make sure that the rod is bent very significantly at the level of the fracture site. And here, this is where the technique of more of a proximal entry site becomes useful. So you put one rod, which is a C-shaped rod from lateral that goes into the distal femur, there. And then the second rod, you have to advance up to the mid shaft and then turn it 180 degrees so that it can go into the medial metaphysis. But the distal ends of the rods have to be, so it's not a C-shaped rod, it's more like a hockey stick. It's really very, very significantly bent distally. And you can understand if you don't do that, you're going to end up with your rods somewhere in the middle of the metaphysis, which doesn't allow you those distal points of contact that you require for elastic stability. Another technique is to use your C-shaped rod from laterally, and instead of using the medial S-shaped rod, you can use a distal C-shaped rod coming from the medial side, provided the fracture site is above, well above in the metaphysis to allow you to do that. So those are some techniques. But I would say you may want to consider plating in distal fractures if you have less comfort or experience with elastic nails. So the distal femoral fractures in the metaphysis are the most, I think, challenging ones.
And just to follow up on that same subtrochlear fracture, is it okay to perforate one of the cortices if you have to, or do you think there is an advantage of going through the greater trochanter and perforate it to get more stability?
I think perforation is fine, provided you don't, puncture right through. Because if perforating provides you that stability into the cortex, so that's fine. The only challenge might be if you're planning to take these rods out and it happens to be a few years later, it's the ones that are perforated out and that are embedded within the cortex proximally that can be the challenge to remove. It's very easy to hang onto the nail and strike it, but if it's buried into the cortex, into the endosteum, those can be the ones that are slightly difficult to remove. But that, I would say that's the only issue. You have no danger of damaging the apophysis. I'm not concerned about that at all. We use elastic nails across the proximal femoral physis into the epiphysis of the femoral head and have not created any growth arrest. So that's possible too. But don't puncture it so that you're outside the greater trochanter, because that can be quite irritating.
Great points. Thanks, Uni. Tarun, should we move on?
So we move on to the next talk by Ben, and that's about still older children nearing to the adults. Yes, Ben. Please share your slides. Please share your screen.
All right. Can you see my slides and hear me?
Yes.
Wonderful. Thanks, Uni. That was fantastic. So moving on to the older age group here in children, the 11 or 12 to 16 to 18-year-olds. So femoral shaft fractures in adolescence. Again, as an outline, we'll discuss some of the background, epidemiology, mechanism of injury and diagnosis, and then the treatment options. So femur fractures may be around 2% of all pediatric fractures, and the other peak of a bimodal distribution across all pediatric age groups may be the adolescents. So This has been said to be the most common reason for orthopedic injury hospitalization in this age group. And again, males more common than females. So our mechanisms are more varied now. Motor vehicle accidents, some of these adolescents are now driving. And we have this crisis of texting and driving. So we need to revisit whether this is increasing in this age group, and then they can be pedestrian struck and bicyclists, as well as recreational motorized vehicles like ATVs and BMX activity. And then sport-related trauma is much more common with contact sports, extreme sports, and then higher energy sports like skiing and the twisting and torquing forces. So the unique features of this age group, their anatomy, they've now developed, near completely and have developed anterior bow. So we need to be aware of that with some of our implants and constructs. They have a thicker cortex and thinner periosteum, so more apt to be unstable with higher energy fractures. And the deforming muscle forces are still there, but potentially with less periosteum helping to hold it. So the iliopsoas on the proximal fragment, adductors on the distal fragment. So again, procurvatum and varus. We also have a slightly less compliant age group and less supervised perhaps. And so we need to ensure that we have more stable fixation constructs. They may progress on their own to weight bearing and take chances. So in presentation, these are almost always, coming through the ER via ambulance. Our diagnostic workup is probably even more important here with making sure to see all the segments of the bone just because it's a higher energy injury. And so while rare, we need to rule out ipsilateral hip fractures with our femur fractures and our secondary survey to rule out concomitant injuries because of the degree of distracting pain with a femur fracture. If it's a higher energy trauma, at our institution, they become general surgery patients. We have a formal trauma service for 24 hours until there's been a tertiary survey and various other injuries or monitoring has been completed or ruled out. In terms of our treatment options, we have multiple treatment options now. We would say using our kind of treatment guidelines, age-based. The rigid IM nails have become a bit of a gold standard, but we have multiple options. So our elastic nails in the older or younger adolescents who are lighter and have stable fracture patterns, as Uni explored quite a bit. Done right, elastic nails should be very good option for a transverse or length stable fracture in a younger adolescent or pre-adolescent. And then our rigid nails are sort of our gold standard. However, there's been an evolution with the use of these in that piriformis entry has been recognized to have an AVN risk. And so it's really trochanteric entry or lateral entry. We know our blood supply comes in near our piriformis entry. And so various studies have shown that the piriformis entry with the young blood supply as we see here, is inappropriate for an adolescent and increases our AVN risk. And therefore, we've evolved towards away from piriformis entry towards trochanteric entry, and now even perhaps more commonly in some centers, lateral entry and specialized pediatric nails for adolescents. Our indications then for rigid nailing would be the older, heavier patients and the comminuted fractures. And so here's an example of one with some comminution, though relatively length stable, old enough, however, to do well with the rigid nail. Compared to elastic nails, the stability, this is, a load sharing device, and therefore you can start mobilization and full weight bearing often right away. Here's another example of an advantage here in that there's something a little funny about this fracture. We see a lucency a little more closely, and rigid nailing gives us great stability through what proved to be a pathologic lesion, assumed to be a UBC perhaps, but with a biopsy discovered to be a fibrous dysplasia. So this was a mini open to obtain the biopsy and a rigid nail to give great stability and early healing here just 3 to 6 months later. Other options include external fixation. The advantages, as Uni discussed, this serves as portable traction. It can be done quickly, so is a good option in the face of principles of damage control orthopedics, like an open fracture or significant polytrauma or vascular instability or systemic issues from a child. It's relatively technically simple and certainly preserves the blood supply, little risk of AVN, and you stay away from the FICS and no risk to growth. Disadvantages as a definitive fracture treatment option, higher rates of delayed or non-union, i.e. slower healing. We have issues with our skin and pin sites. There's a question of patient satisfaction, and as well as a reasonable refracture risk upon ex-fix removal. So our indications may be open fractures. Here's a case of angulation, and then here's a case of refracture through a previously external fixator applied fracture. Another option for the adolescents is submuscular plating, favored by some. The advantages would be the sort of MIPO technique, though some would question how minimally invasive it is. You can mobilize these patients early as well, though some would say it's somewhat technically demanding, so it does require experience with the technique. And unlike the rigid nails, it's load bearing rather than load sharing. And so weight bearing protection needs to follow use of the nails for a longer period of time. There also may be a role for secondary surgery. We'll talk about that in a minute. So here's an example of a submuscular plate placed distally for a length unstable fracture. This patient's a little bit younger, closer to the upper limits of that middle age group, but you can see even a little bit of angulation in the sagittal plane can do well. One thing we learned actually during my fellowship, Dr. Hedequist mentioned that he had seen a couple instances of valgus deformity below the submuscular plate. And so we did a deep dive on every submuscular plate done at our institution as this technique became available. Boston Children's and Denver Children's were amongst some of the earlier institutions to adopt it. So we had a number of cases to look at with Dr. Hedequist and Tim Resco. And so I looked at the position of the plate relative to the FICS, as well as all the alignment parameters radiographically in patients over time. And what we found was for the plates that were placed close to the FICS, and this tended to be the distal fractures, we tended to see this valgus deformity arise in the years after the plate. And so 30% of patients with distal fractures and over 10% overall developed pathologic valgus, many of whom needed growth correction, some after they had completed growth, i.e. requiring osteotomies. And so our rules basically from this study are that if you place the plate within 2 centimeters of the FICS and you have 2 or more years of growth remaining, you should plan to remove the plate. And certainly for everybody, you should plan to monitor and think about hips to ankles films to make sure this doesn't develop. In terms of the submuscular plate technique, we tend to favor the lateral DQ position, allows for easy entry as well as easy radiographs. And you can see this setup. So here's a fracture that was length unstable. We placed our plate, found the length, applied the flare. So we use our plate bender, which is a large plate bender. This plate had some degree of bow to it, matching the bow of the femur. So then you can use sort of bridge plating techniques with distal screw and proximal screw to maintain your length, make sure your lateral shows that you're lined up nicely so that your additional screws can then give you near anatomic angulation and reduction in both planes. So here's that plate bender and the final construct for that fracture. So again, going back to our femoral fracture algorithm, while we have good other techniques such as plate and external fixator options for the adolescent group, the rigid IM nails are probably the standard. And here's just complications to keep in mind. Non-union and interlock screw irritation can happen. Here's a case of a non-union with a rigid nail. So you need to be mindful of your distraction and attempted compression techniques at the end of the case before you affix your interlock screws. Sometimes we can't quite explain why it happens. In this case, time passed and this non-union. So 4 months after the original entry, dynamization was pursued. So the distal interlocks were removed, allowing weight bearing. And we see a brief hint of some healing, but still persists 3 months after dynamization. So now what? 4 months after dynamization, we still don't have a healed fracture. Occasionally we need to get creative. So rather than remove the rigid nail, this was left in place and plated around the nail with compression techniques. And this went on 3 to 4 months later to heal completely. But these complications can arise. And as Uni mentioned, we want to have multiple quivers or arrows in our quiver and options with plan B always ready. So thanks very much.
Thanks, Ben. Sheetal, do you have any questions?
Well, that's a great overview, great talk, especially focusing on plating and rigid nailing. Do we have any questions from the audience? Otherwise,
yeah, Sheetal, we have a question for Uni. Yes. Somebody is asking, how do you symmetrically bend the 10 nail? Can you give some practical tips? Both the nails, how would you symmetrically bend so that they span out exactly at the practice site?
Yeah, I think there are many ways to do it. It's very important that you're bending the nail in the plane of the contour tip, so that when you're looking at the radiograph, you know what the plane of that bend is in the image intensifier. Some of us use an external bending device. For rods that are 3.5 millimeters and less, it's easier to do it by hand. I'm not strong enough to do the 4 millimeter nail. In the mid shaft, you can, but closer to the tip, it's very difficult to bend it. In the set, we've got this F tool that's got a hole in it with levers. You can use that to bend it. There are various techniques. But to ensure that they're both the same, I put the rod on top of the femur and mark where the proximal end should be, where the fracture segment is on the thigh, and where the distal end should be. And I mark that on the rod so I know where to put the bend. I then make the bend and I do both together. So I get both done before I put the first one in. So I've pre-bent my rods to make sure that they're matched.
There's one question for Ben. What is the youngest age you have used anti-grade nail, trochanteric locking nail? What is the youngest age?
Yeah, personally, I've done some around the 8 to 9 year age group, and a nice report from the Campbell Clinic in Tennessee has suggested that really the same middle age group that Uni discussed for elastic nailing can be treated with rigid nailing without a report of AVN from that group. I think this is really the introduction of the lateral nail, staying well away from the blood supply, and a specialized technique or implant, basically, that are smaller sizes to accommodate these younger children. And so people have had good good results with that. It's sort of maybe early. We certainly know there are some AVN cases out there, but we don't have a firm rate, and we don't really have 10-year data on the technique. So I think, though, from studies that have been published, you could say as young as 7, 8, 9 years old is acceptable for rigid nailing, provided there's attention towards entry point.
Taral, we have few questions, but I am sure that you will be able to answer them during the case discussion. I think we move on to the case discussion.
Absolutely. So let's move on to the cases, and we are running a little late, but it's been our philosophy that time can wait, but the knowledge will not wait. So even if it extends by around 15-20 minutes, I think we would request the audience to have patience and be with us. But let's go threadbare in this topic. So I'm going to share the slides for the questions. And it's very heartening to know that people have joined in for these sessions. And you can see how the Saturday evenings have changed. So these are 3 generations of Agashes: Dr. Vikas Agashe, who's orthopedic surgeon, and Mandar Agashe, who is the scientific coordinator. And then you see Vyom, his child, and all 3 of them hooked on to iFICS 2020, watching it live. So you have a very young pediatric orthopedic surgeon in making, who is learning right now how to manage fracture shaft femur in children. So that's what is the power of knowledge. So let's start with neonatal femur fractures. I want to invite Alaric. Alaric, please come on, and we will start with this case. Ashok, turn the poll on. This is a newborn with a femur fracture. Let's have the poll, and then Alaric will take over. Please start the poll. Everyone, please start voting. We'll have 10 seconds to vote.
I think you have had a good discussion from Benton already, so it should be pretty clear. But it'll be interesting to see the spread of the answers, if there are any other choices, because there are choices here.
Yeah, Alaric, this is what the audience feels.
All right, that's great. So we feel that 83% will vote for a Pavlik harness, 8% would use 6% a gallows traction, 7% a hip spiker, and 4% would use none of the above. So that's interesting. Maybe we can have a discussion on what that means, if there are other methods of treatment as well. And I'm sure there will be something from the audience who have sort of innovated their own methods for treating a newborn with a femur fracture. All right, let's go ahead. Can you have the next slide, Taral? So this was what was done with this fracture, and this child was put into this extremely ghastly looking hip spiker. And I think this is the challenge that Benton spoke about, putting a really tiny baby like this. You can imagine how difficult it would be for the parents to take care of a child who is immobilized in this manner. Besides the fact that it's uncomfortable to the child and difficult for the parents, you can see that there's quite a bit of malalignment that Benton spoke about. And the key to understand here is that these fractures are by necessity flexed, abducted, and externally rotated because of the pull of the proximal fragment. And the distal fragment must therefore align itself in that position. And that's why any device which allows the distal fragment to follow the proximal fragment in flexion, abduction, external rotation is the right device to use. Whether you're using a Pavlik harness, a Von Rosen splint, whether you strap the thigh to the abdomen, or use a Pavlik harness, or even a gallows traction. I think the key here is to understand how to align that distal fragment to the proximal one. Let's take the next one. So as you can see, as Benton rightly pointed out, these have a very good remodeling potential, but there is a limit to which you can push nature. And I think what's more important is we have seen parents sometimes who are quite upset when they see x-rays like this. And it's not just the x-ray, but even the fact that the child has a visible bump over the anterior lateral aspect of the thigh, which requires a whole lot of counseling to the parents to assure them that the fracture will remodel over time. So you'll have upset and angry parents in your clinic for almost 6 months till that bump goes away. So here's another fracture. And as you can see, that what Benton spoke about, treated with a Pavlik harness. And I think it's a good thing to have each of us have a Pavlik harness in our clinics, even if you're not doing pediatric orthopedics as a specialty. it's a multi-purpose splint. It can be used for DDH, can be used for fracture sharp femurs in neonates, as you have seen. And this position of the femur allows the distal fragment to realign with the proximal fragment of flexion, abduction, external rotation. As Benton also rightly pointed out, we don't need to flex the hips more than 90 degrees as we do for DDH. So the risk of a femoral palsy is much less. The only thing to remember is that it does not provide much support in the form of rigid immobilization like a plaster does. So these children are a bit fussy for the first few days. It's important to put a little roll below the knee on the lateral aspect so as to prevent that hip from falling into a severe external rotation and abduction, and also not to move the child around too much for the first few days. A good question, I think, a poll that was sent to all the delegates beforehand. Do you have a Pavlik harness in the place where you work? And that's interesting because only 23%, and I'm assuming most of the delegates are from India, but I'm sure it's true for most other countries in the developing world as well, that off the shelf, only a quarter of the respondents had a ready-made Pavlik harness. 30% didn't have a Pavlik harness, and a sizable amount had to order it. And we can understand it takes 3 to 4 days sometimes to get it to order. And that's not going to help much because by that time it's already healed up. Dr. Chandak, would you like to speak about this?
So commonly to us, it's not available. And I tried getting it one, but it was not fitting to all the neonates. So I usually treat like a back slab and a front slab, and wound carefully with padding of all the bony points, taking care of flexion, external rotation, and abduction to the hip. And as passionately we apply Ponseti cast, similarly in this child, taking care of all the bony points and the pressure point, and allowing parents to take care of the hygiene for the perineum. That is the points I would like to mention for this.
Sure. So thanks, Dr. Chandak. I think that's a wonderful, innovative measure. I would probably add a little more flexion around the hip and the knee so as to get that distal fragment to align itself well. I think we must be aware of the fact we should never immobilize these in extension. I think you've done a wonderful job of showing how you've kept the hip and knee flexed with a plaster slab. Maybe adding a little more degrees of flexion would be also a good thing. Another way that was used for quite a lot of time originally, and we have learned this from some of our teachers, our senior teachers, is to strap the thigh to the tummy. And that's also an acceptable way, but we must understand this is at best a very temporary measure. It's not comfortable to the child or to the parents. It can have a risk, especially in our warm climates, because of the sweating that we have in humid climes, that you can get a lot of rash in the flexural creases of the thigh and of the hip and the knee. So be very careful when you overflex the hip as well. In warm climates and humid climates, it may not be so applicable. And that's another device that Taral has shown. He's also brought up this case where it's sometimes challenging. You have to think out of the box. Here's a neonate who has contractures, and that's a child with arthrogryposis. And we know that this child has an extension contracture of the knee. Here, of course, then it becomes much more challenging because now that amount of flexion that is required to immobilize this fracture is not possible. So we have to again think out of the box when you have rare syndromes like this, where the child has an extension contracture, and here it might be suitable to put this child in a spiker cast. Maybe here a one-leg spiker should be fine. Let's remember the fact that not all of these are innocuous. We know, as we have mentioned before, that neonates have a very high remodeling potential, but don't challenge nature too much. This was a 3-year-old neonate that I had a chance to treat many years ago, treated elsewhere outside with a spiker cast. And as you can see, given the traditional manner with the hip in extension. Next slide. And when we saw this child on follow-up, this was at 3 months down the line, this child actually had a non-union. And I think it's the first time I've seen a non-union in a neonatal fracture. This child had no other features of neurofibromatosis. Of course, I understand that some of the features may present later on, but we followed the child for almost a few years and there was nothing to suggest fibrodysplasia, neurofibromatosis, or osteogenesis imperfecta. We actually had to do an open reduction. We found there's a lot of fibrous tissue interposition. We had to plate it, and that's a 2-year follow-up. And I've seen this child recently, and the child is doing extremely well. So just to bring up the point that these are not innocuous fractures. If you don't immobilize them in the right way, you can have a lot of issues. So thank you very much for that first step.
Can I ask a question?
Yes,
yeah, please.
I'm curious from the panel if anybody has seen, with the exception of the last case, which was a non-union, which then became evident later on. But while I completely agree about the use of the Pavlik constant, which is what we use, because it brings it to that position of flexion, abduction, external rotation, the principles in my mind are really as a splint to keep the child comfortable in a reasonable alignment. But I have yet to see, because they come treated in all kinds of ways before we get to them, we see them sometimes, and I imagine that's true in India as well. I've yet to see a single patient, no matter how badly it was aligned, that had a problem in the future. And as long as we had that lengthy conversation with the family with other radiographs to show them how this remodels. So I'd like to know from the panel, have you ever seen a malunion from a poorly treated neonatal femur fracture? I'm talking about a neonate.
So I would say that I saw a child who had a severe amount of external rotation. It took quite a lot of time to remodel. Now the question is that how long can you keep convincing the parents? So this child had a severe external rotation deformity for a good 2 years that took a lot of time to get into place. So though while I agree, the varus valgus and the coronal alignment tends to remodel over time, usually within 6 months. Sometimes that severe external rotation deformity can take much longer. This child was walking with an external rotated gait for almost 2 years. The parents were really unhappy. So I think the more we align it with as much as we can, it's always good. Of course, we know nature does wonderful things in these children, but ever since I saw that non-union fracture, which had no explanation besides the fact that it was badly aligned, I have become really cautious about taking these too lightly.
Ben, would you like to answer that? Your views on?
Yeah, I would agree with Uni. I think the scenario of that significant malunion or symptomatic malunion is out there, as cases have shown, and I think there's a study from that same group at the Campbell Clinic, Derek Kelly and James Beatty and others, that the Pavlik harness can lead to malunion that takes many years to remodel. I personally, I think we're hard pressed to find the child who's actually, dysfunctional. But it can happen. So you need to be mindful, but it's quite forgiving in this younger age group. So.
And one of the things that I'd like to bring up, if you have time, is many of these malunions are defined based on the residual angulation at the fracture site. That's how all of us report at 2 years or follow-up. But we know that 70% of the remodeling occurs at the FICS, distributed proximally and distally. And only about 25% to 30% occurs at the actual fracture site. So there's a huge lag. So in fact, the femur may have completely remodeled as far as the mechanical axis is concerned, and it takes longer for the diaphyseal angulation to fully recover. But which probably explains why many of those patients, none of them end up requiring corrective osteotomies or any particular treatment. So we have to be careful that the literature may be misleading because we have focused on defining the malunion based on the residual angulation of the fracture site.
Okay, so let's go on to little more older children, and let's see how it behaves and what's the audience choice here. So Ashok, let's have audience poll here. This is a 3-year-old child. We are moving on to an older child, and these are the options. Can we have the opinion poll? So we have around 10 seconds for people to vote. And, it's almost like Indian elections. There are trends happening, and I'm going to end the poll here and show you all the results. Everyone can see that 51%, almost 50% wants to go for immediate spica, but closely followed by traction, followed by spica, and then elastic nails in a 3-year-old child. So I want to ask Ben, what would be your choice for this patient? 3-year-old child with femur fracture.
Yeah, I'd be curious to hear any of the panelists' rationale for the benefit of early traction with delayed spica, just because I feel like the results of immediate spica are quite similar, and if not equivalent, and it takes away the need for additional hospitalization, and of course there's muscle relaxation, and there can be some development of some early callus instability, making the spica go better. But if you're mindful and can take intraoperative or pre-anesthesia wake-up x-rays to confirm good position and you're comfortable with wedging techniques or revising your spica, immediate spica has been shown to be quite effective. So that's what I would favor.
Absolutely. So it's going to be conservative, immediate spica or traction, as audiences have said. But this child, with the entire range of operative treatment, to what extent it can go on, is that he was treated with a nail and, 2 elastic nails. Only, do you think, where do you categorize this? Is it effective nailing, suboptimal nailing, or this is a disaster? What do you feel this is happening here?
We can be very nitpicky and criticize a little bit of the technique, etc. But I think we're losing sight of the big picture, which is that this fracture is going to heal no matter how you treat it. I would say that the indications for an operation in a 3-year-old, would push me if this was a bilateral fracture, or if there was an open fracture, or if this was a polytrauma, or there were some caregiving concerns that the parents particularly had. You could, so I would say, if you're then going to use elastic nailing techniques, you want to follow the principles. But again, in a 3-year-old and a smaller kid, you can get away with a lot of mistakes, as you're pointing out here. But
so there is a distraction at a fracture site, and this took a very long time. A 3-year-old child put in spica, the fracture would heal in 6 weeks' time. But this is almost gone on for 4 months, and it's doesn't show yet signs of healing. And when it healed finally and the implants were removed, you can see there is a lengthening of a centimeter at 18 months age. So it's not that an operative treatment does not do any harm. It can also do a harm or a result which is not desirable. And at this age group, when a non-operative treatment can give you a good result, a good comfort, I question the indication in this child.
I would agree.
Yeah, so let's move on to Sunil Vijay Singh from Sri Lanka. They have a very unique way of managing this fracture shaft femur in children. I've seen this at the hospital, and this has been going on for many, many years. So Sunil, can you please
Yeah, can you hear me?
Take us through this. Yeah.
Hope you can hear me actually. Now, after listening to various modes of treatment and about managing these children, and Ben said that there's no ideal method of managing these children, and then so yes, there's no ideal method, and this is the method that we use, one simple method in our setup, and we were able to get a reasonably good outcome, or good outcome when you compare with other methods. And this is a 2-year-old child, I think, with this proximal femur fracture. We manage its skin traction, and this is a supervised skin traction, and we keep them in the hospital in the ward for about 14 days till they develop a soft callus. The child is comfortable, pain-free, and then after that, our protocol is to send them home to manage with the home traction. And this is 1 month X-ray, and this is X-ray at the end of 2 months. And the next slide, the 3-month X-ray, child is walking well, no complaints, and then function is basically normal. So what I want to show is that she didn't have any skin complications, and show is that even with these simpler methods, the final outcome is more or less equal to the other method that you all have, both Ben and Uni has described.
So you don't need anesthesia; it's just skin traction in the ward. Right?
Yes, it is basically you keep the child, give some sedation, or keep the child, give some things for the child to sleep, and then give skin traction. Only the protocol that we follow is you apply skin traction and then take a inward X-ray after 24 hours, and then traction is 1/3 of the body weight, and it is supervised skin traction to make sure that to keep some sandbags on the either side to prevent the rotation of the thigh. And then when the soft callus forms, you discharge the child after discharge from the hospital, and then advise parents to do the same traction at home. And then it depends on the age of the child, how long you are going to keep the traction, and then you follow up in the clinic, and then finally get the result. So this child.
So let's have opinion poll. Sunil, let's have an opinion poll, and what does the audience feel? It's a lot of abrasions, road traffic accident,
yes,
femur shaft fracture in a three-year-old.
3-year-old child who came following road traffic accident, actually thrown away from a three-wheeler, and then had a lot of abrasions over the thigh as well as over the knee and the leg. Of course, then because of these abrasions, it was difficult for us to go with the skin traction. So we'll see how the panel, how the audience thinks about this management of this one.
So I'm just going to announce the results here. So traction followed by spica, 33%. So once the wound is healed, 31% for the external fixator, 16% for elastic nails, 10% still feel that immediate spica could be given, and 10% want to give only for traction. I'm going to ask Ben, if this patient came in Boston Children's Hospital, how would you manage this child, 3-year-old child with this kind of issue?
Yeah, I think this is the part of my talk, that alluded to, those rare indications for the school age or preschool children getting an elastic nail. Both skin traction as well as spica casting is made difficult by the presence of these skin abrasions. And with a fairly simple procedure, despite it being a little bit length unstable, I feel that elastic nails, while needing a removal of hardware procedure in this age group down the line, that can be a fairly, a small perturbation for the family. So I would favor elastic nails in this 3-year-old.
Well, I would do the same thing, but let's see how they manage in Sri Lanka. Yes.
Yeah. We put a small, because there's no way of putting skin traction because of these abrasions. We put a small K-wire through the upper tibia, like use as a skeletal traction. And then the 1/3 of the body weight, and all the abrasions were healed with this method. And then this is the X-ray on day 14, while you can see the child wide on traction. Good healing, good alignment. And then this is the X-ray at 5 weeks. And then, so all the wounds were healed, and then there were no length or rotational issues when this child came to the clinic.
So one of the question I was, I asked Sunil when I went to, Sri Lanka, and we saw this, that why not elastic nail, or why don't put spica? And his answer was that, Taral, I'm the only pediatric orthopedic surgeon. We have so much of work. I'm the only one treating everything which a child has. And by the amount of femur fractures and supracondylar fracture number we get, if we were to treat everything by by taking them to OR, I will not have time to treat the club fit and DDH and osteogenesis imperfecta and post-infective problems. So Sunil, so situational orthopedics is the word which Sandeep has coined. The same fracture, different situations, the treatment methods can be different as long as you are taking care of the length, stability, and deformity, the L, S, and D. The principles are correct. It can be treated in a different way.
There's another reason, Taral, actually, other than the reason that you mentioned. Basically, when you offer all these options for the parents, of course, they with the results that we have got with the skin traction, they opt for the most simplest option. The question in our country that the treatment is free of charge, and then they don't have to spend extra for staying for a longer period of time. So they prefer to stay as long as the treatment is less invasive and giving good final outcome.
So my question to Uni is, Uni, how much does this matter? The social circumstances in decision making, the family participation. Yeah.
I think it matters a huge amount, and that's where the literature is missing. So we are working on a patient-reported outcome measure for fractures, and it has 4 domains. How it looks, how it feels, how it works, and how it healed. So that 4th domain, what was the journey from from the injury to when it fully healed? That may be where the difference. I think this is why this is a rare example where it is actually nice to have these multiple options, because under different circumstances, each of those options may be the optimal method in that particular circumstance. And when you do genuinely have a choice between 2 or 3 options, we have to have a way of communicating that to parents and families so that they can make an informed choice of which will be better in those circumstances. Sometimes it's very clear that there is one best option for a particular injury, but in many instances, that's not the case. And we need more information about that. And I think as we develop our outcome measure, one day it'll become like consumer reports. For treatment X, it's very good in this domain, not so good in that domain, but very expensive, etc. And then people can make more reasonable choices, because all of them can work. And it's just a question of which advantages and disadvantages apply in a particular circumstance. So
in fact, we have got very good results up to the age of 8 years with this kind of conservative management, even though we talked about flexible nails are the preferred choice of treatment at that point. The point is, like now we apply 1/3 of body weight, 1/3 of body weight as a traction, and then generally the skin, the skin tolerates about 8 to 10 kilograms. That is our experience, without any aversion of the traction kit or without any skin complications. So the 8 kilograms means the child is 24 kilos weight. And in our setup, I think in our countries, when the child is about 24 kilograms, child is around 7 to 8 years old, maybe between 6 to 8 years. So up to that age, we were able to manage these children with fracture femurs without much of a problem, with good outcome.
Absolutely. And a 5-year-old child in US and 5-year-old child in India is different. Meaning a 7-year-old child in India or Sri Lanka has same build and weight as a 5-year-old child in US. And second, issue is the anesthesia, because when we took an opinion poll of all the participants of FICS, almost 70% feel that they don't have a good anesthesia for a child who is less than 3 years. And, in those children, to give anesthesia and do immediate hip spica, rather than that, people may prefer giving traction. And this incidence also may change between Bombay to Nagpur. So you have from Nagpur, Dr. Chandak again, who has this very nice buck splint. He has designed it himself, where you can give straps, immobilize, give traction. And this is something patient can take home, so that the amount of length of stay can be reduced. So let's go on to some more cases. This is a 4-year-old child, and he has 2 centimeter shortening on telescoping, and this child was treated in spica, and this is the result I have got in spica. I want to ask Ben, is this acceptable? You have an angulation, you have little overriding. Should we accept this in a 4-year-old child, or should we do something else?
Yeah, I think there are techniques by which you can, with a spica cast, address the telescoping and the shortening. But if it persists and proves to be difficult, it could be an issue. Up to 2 to 2.5 centimeters is often tolerated, just because we know overgrowth tends to be a phenomenon that then makes up that length. The one advantage of fiberglass spica casting is the wedging, and that can be done with plaster too, but much more difficult. So the slight recurvatum could be addressed with wedging of a spica cast, but this is close to potentially leading to a leg length discrepancy.
So you're right, he did have a leg length discrepancy of 2 centimeters. The alignment got fairly well corrected. The translation, it is there, but we just persisted with him, and you can see him after 4 months, and then after 2 years, He almost corrected his leg lengths. All the translation and angulation was corrected. So children do have remodeling potential, but it's limited. It's limited to maximum to 2 to 2.5 centimeters. So if the shortening is more than that, it's not going to correct. And we need to be looking at all the options where length, stability, and deformity is taken care of. How to give a good spica? So we have Sheetal here. Sheetal is going to share some cases as to avoid problems within the spica. So Sheetal, can you please tell us about some of the cases where spica was an issue and how did you manage them?
Okay, if you can stop sharing, then I'll share my screen. Okay, so you already have it on your side.
Right.
So this is, a 3-year-old child. Can you move to the next slide? So this is an acceptable reduction. But this is after 1 week. The patient had severe soiling of the cast, a lot of skin rashes, and had dermatitis, which we usually treat with some local application of an ointment. What are the options now? If you have someone that you showed another similar case where there were rashes on the skin. And we have certain cases as well where there is a skin issue. So what would you do now? And, we talked about, elastic nailing as a backup for younger patients. So I'm a little bit different than others is that even if you use elastic nailing in a very young child, you may not follow the principles of elastic nailing. You can get away just by putting one nail, and that should be sufficient. So, this patient had 2 nails, but I had patient just 1 nail, very young child, skin issues, 1 nail and a splint, and that would be sufficient. Here is an example of a 2-year-old boy who had a left femur shaft fracture, had a spica cast, and the cast stayed wet for 2 weeks. Okay, and the patient came back with fungal infection of the skin. There was mold on the skin, and of course, the fracture had kind of, 2-year-old, so fracture is stable at around 2 to 3 years of age by 2 or 3 weeks. So had a knee immobilizer, and then we just put some Aquaphor, had a dermatologist just look at it, and it cleared up in a week. And so it's important that we pay attention to taking care of kids in spica. It's, the number one complication of a spica is skin issues, and you have to be careful about how you apply the skin. This is another pressure sore from a spica. So there are even compartment syndromes reported with spica cast application. It's not all without an issue. So the other thing is the mold that we talked about. We always want to have a valgus mold. Normally your femur has some procovatum, so I usually don't mold in a sagittal plane unless it's out of plane. But a varus mold is important here. Even after putting a varus mold, you can see that there is still some residual varus. So we talked about wedging, and I'll just show you a technique of open wedging, where you leave the outside of the lateral aspect intact and take out the wedge. I don't know if the video is playing here, but you open it, do an opening wedge, put your the wedges, and then check again with an X-ray, and you can correct your varus. Just leave an intact cast on the outside, and you can see that this is pre-wedging on the left side, and after wedging the cast on the right side, and that should correct your varus. So wedging is a very efficient technique. What one should avoid is this 90-90 cast, where compartment syndromes, Walkman's contracture, skin loss, and requirement for skin grafting, all those significant skin issues have been reported. So I would definitely recommend, and the way that they have done this, or they were doing in the past, is to put a short leg cast first, then pulling with the short leg cast to bring the femur to length, and then putting the entire spica on, and that leads to compression of the neurovascular bundle at the popliteal area. So you want to avoid. There are a couple of other options. We saw the traction being an option for shaft fractures. Here is a brace, which is a prefabricated brace with a Pavlik belt, And you probably may reuse these. So if you have 2 or 3 different sizes of a brace, this study on 41 fractures treated with the brace won the POSNA award in 2016. So that's definite a way of treating, avoiding going to the OR. If you have anesthesia risk, like you just mentioned, having a brace like this in 3 different sizes, small, medium, and large, may give you an option to treat the fractures just in a pre-made brace. And other things, what I wanted to talk about, which Ben raised an important point about immediate spica, is what we have done. I think traction and spica was a technique that has been described. I've seen it being used in India, but I don't see a downside of immediate spica casting. So, the other thing about the cases that Dr. Sunil from Sri Lanka showed about the traction, I would tell you, I've seen a photograph of a femur ward. Okay, Dr. Crawford showed me a photograph at our hospital. There was a ward for femur fractures, all patients in traction. Okay, and not just up to 8 years, even the adolescent patients in traction. So the fracture heals. Okay, in traction, the fracture would heal. Whether you give a straight line traction or you give callus traction, it is not about healing of the fracture. It's more about convenience. It's more about managing patient and family expectations, and it's more about mobility for a fracture. So if you have a spica cast, you can transport the patient from one place to the other. With the traction, it's very difficult. So it's and same with other fractures. Tibial fractures have always healed with the Sarmiento until we nail them. So the issue is about convenience, and treating it with a traction or with the brace or something. It's not like it's an easy way to treat it. If you say that you don't have enough time because you're busy, well, that is I think that treating these patients with traction actually is more time consuming, because you would have to take care of proper traction. You'll have to take periodic X-rays, make sure that everything's okay, and even at home there is no mobility. So I think these are alternate ways of treating the same fracture, but there are pros and cons, just like what Uni had mentioned. And I would not put skin traction as the simplest or easiest method. I think there is maintenance issues with each of these methods. And sometimes putting a single nail in a 5-year-old may be much easier than treating it with a traction. So, depending on the resources and what is available to you in your area, I think these are all valid choices, but it's not like simple choices or non-operative choices are always better options. They are demanding.
So let's see an example of how it's not always easy to manage a child non-operatively. So this is a 7-year-old child, has mid-shaft short spiral femur fracture, and let's have the poll on. And let's ask our audience, how will they manage this patient? Ashok, can we have the poll started? Yeah, you have 10 seconds to vote for this. So beauty of this is, you can have 100 opinions at one go for a given fracture, all coming from different geographical areas within the country, outside the country, from throughout the world. And very interestingly, almost 90% prefer elastic nailing, and people don't want to go for conservative management. So now I'll show you what was done. This patient was managed in a spica, and I'll directly show you what happened after 6 months. So he has 25 degrees of varus, 19 degrees of extension. But more importantly, if you check the rotation, there is exaggerated internal rotation, and he walks with in-toeing. It's very difficult for him to walk well, and he cannot sit cross-legged. And there is 3 centimeter shortening. So only you spoke about the fractures in this age group. How do you place this result? What has gone wrong, and how could this have been avoided?
Can you show me the X-ray again?
Only before you answer, there is a question that in spica, how do you check the rotational alignment in a hip spica? So if you can cover that question as well.
Absolutely.
Okay, I'll answer that question. I wouldn't offer a spica cast for a 7-year-old in general, but how you address the rotation is intraoperatively, we set up the image intensifier in a way that after when we're still doing the actual mold, so we have an opportunity to make alterations, I make sure I can get an AP X-ray of the hip and an AP X-ray of the distal femur orthogonal to the actual slope of the femur to make sure that you're getting an AP of both on both views. So that's typically how I ensure that. Now, with respect to this, Tarol, could you go back to the X-rays, please?
Yes. Previous one?
Yeah, this one. This is fine. This is no, just to the yeah. So right here. So, clearly there's a limit to how much a fracture can catch up in its length, and that's about 2 or 2.5 centimeters. It's almost as if when you take the tension off the physis, it doesn't overgrow. Very, very rarely does it overgrow. It's more like catch-up growth. But there's a limit to how much it can catch up. And I guess that's around 2.5 centimeters. As far as angulation is concerned, I'm less concerned. So again, here, there's 25 degrees of varus and 90 degrees of apex posterior angulation. Look at the contour of the thigh. If that's not visible on the outside, and you can look at it, if that's not visible on the outside, I would wait because, like I said, the action is not here. It's not at the diaphysis. The action is at the physis. So the line I'd like you to draw would be from the center of the hip to the center of the knee, and then the distal femoral joint line. So you can tell me what the lateral distal femoral angle is. That line will capture. Those two lines will capture how much remodeling has occurred at the physis, and I'd make my decisions based on that. Now, with respect, yes. So if you can now draw your horizontal line through the distal femoral joint line, you can see, now that may not be perfect, that on the lateral side is close to 90 degrees. It should be about 87 degrees. It's certainly not 25 degrees of varus. And you can do the same on the lateral view as well. Now, with respect to rotation, we know that doesn't remodel. And if he's walking with an internal foot progression angle and is trying to make adjustments for that and walking very awkwardly, that I'm afraid you have to address. So I would say that's what I'm really going to be addressing for my, later on, if that persists. Now, with respect to, let's just say there is a 25 degree or a 15-degree varus in this particular instance. If you're going to straighten it using, at the fracture site and make that straight, if there has been compensation at the physis, you may actually create a distal deformity. So that's something you need to take into consideration as well. So angular deformities, a rule of thumb in these young children, if it doesn't look bad on the outside, it's probably going to be good on the inside eventually. The length, there's a limit to how much you can accept, and rotation also. So in this instance,
one other thing I would just add to the spica is, like, based on the level of the fracture, you may have to adjust the position of the leg in a spica. The proximal fragments tend to flex and externally rotate, so it should match, the position of the leg should match where the proximal fragment is. But for typical diaphyseal fractures, if you use like a 30-30-30 rule, 30 degrees of flexion, abduction, and external rotation, it most likely, you may have to vary a little bit, but most likely would match with the proximal fragment, and you won't have any significant deformities unless you lose reduction afterwards, but at least it will match the rotation, so if that's your concern. But if you have more proximal subtrope fractures, you'll have to flex it a bit more. So just kind of a guideline.
Yeah, I think that's very, very sensible, Sheetal. But regardless, I think it's important to check, because having these absolute rules is fine as a guideline, but then you want to check radiographically. And I think if you get the AP and lateral without moving the C-arm or moving the leg, then it's very reassuring that you've got the rotational alignment to something that's clinically acceptable.
So what we learned from the last case is that it's important to look at the length, rotation, and the deformity, all the three, And it's important to look at rotations, whether you're doing spica or nailing. You can be doing nailing and still get your rotations wrong. And it's very important to look at knee and the hip when you're treating fracture shaft femur. So let's go to the next poll. This is an 8-year-old child with fracture shaft femur. Short oblique, almost 2.5 centimeters, telescoping test. How do you manage? Let's start the poll for this. Ashok, can we have the poll? Yeah. So 10 seconds to go. Can you see the poll?
We can't see the poll.
Okay, okay, I'll launch it again. Okay, here is the poll.
We still can't see, sir.
Yeah, can you all see now?
I was able to see and to vote. I don't know about others.
I think people are voting, almost 102 votes. And let me end it now. And again, most of the people want to go for elastic nailing here. So Unni, in this child, we were going to do elastic nailing. This happened on 25th of March. And then we admitted the child. This child we admitted and did this nailing. So any how does this nailing qualify as per your opinion?
At first glance, I think it looks fine. You've got a balanced configuration. The question is what the size of those nails might be. On the lateral side, you can see that you might have been able to squeeze another 0.5 millimeters out of each nail, but that's a judgment call you have to make. The overall spread looks pretty good, and like I said, you've got a balanced configuration here. Now, one thing that and the lateral is, you've started, and this can happen on the medial side where it's not a perfectly flat surface. Your entry point is a little bit more anterior, but on the other hand, this is not a true lateral view, so that can be a little irritating. But this looks fine to me. One of the things that I do with stability is don't take anything for granted. I test the stability of these fractures intraoperatively as well. So it's not just the X-ray. You can also test it and reassure yourself. But that looked fine to me.
So healed well. We removed implants at 9 months, no issues. Later on, the child came back at 2 years, and mother felt that he was walking a little funny. He actually ended up with lengthening of 2.5 centimeter on the operated side. So this is the question again. A lot of delegates have asked that if you match the leg length in a child who is between 5 and 11 years age with help of a nailing, what are the chances that actually it will overgrow in 2 years' time? And how do you manage this?
Right. So I will say that it is so rare that you shouldn't worry about it. I think you should aim for as close to anatomic reduction as possible. In spica casts, you don't have to aim for that because it's hard to achieve anatomic reduction. You accept some shortening, it'll catch up. While this can indeed happen, I don't think it happens so infrequently that I don't think you need to alter your protocol in order to avoid one problem, because not having you can't really use elastic nails in a shortened way. You either have it aligned or over distracted. As long as it's well aligned, like I said, this is quite unusual and is manageable. If you wait some time, you may find that the other side catches up, or you use an appropriately timed epiphysiodesis. This is why it is important to follow these patients, up to at least 12 months to see that there are no length differences. But like I said, this happens very infrequently.
So nature has some way to judge the, sort of a tissue tension. So if it knows that there is some shortening, it makes up for it by lengthening. But if the tissue tension is good, so with nail, very rarely we would see a lengthening. And this is one of its case where we had to manage actually by doing a growth modulation to control the growth, and then it ended up well. So this is a 6-year-old child with a femur fracture, long spiral, again, length unstable. It occurred on 4th May 2020. And, I really don't want to put through opinion polls, because I know everyone wants to do nailing, and that is why this patient was admitted to our hospital for nailing. The issue was we had to do a COVID test, and she turned out to be COVID-19 positive. And I want to ask now, with this situation where, she's sharp femur, you want to operate, she's COVID-19 positive, what would you do? Sheetal, in Cincinnati, in such a situation, what would you do? You will take all precautions and still go ahead with nailing, or there is any other option in this child?
Yeah, no, we go with the standard treatment. All patients get tested. We have had positive patients that we have operated on. Yeah, precautions means we don't use the entire thing that I've seen, like the gown and the respirator that I've seen in some photographs, and especially in India where friends have told me what they wear. We use an N95 respirator and just our general precautions. Only thing is we are not present during intubation time in the OR. It's only the anesthetist and the support staff, like 2 other people. And we wait for 10 minutes once the patient is intubated. You have to be careful about, drilling and, bone dust and all those stuff. It's better sometimes to keep it limited. But I would still go ahead with the standard treatment. I would not change it just because the patient is COVID-19 positive. And one other thing, I'll just bring it up because we are short on time. But, when you ask someone, like, how does this nailing configuration look? It is very easy to criticize any nailing, configuration in hindsight, saying that, yeah, this could have been better. The nail tip should have been this way. The nail should have been bigger. But when you are doing the surgery, I have purposely sometimes violated the principles of balanced nailing because the fracture geometry would not be perfect unless I turn the nail a certain way. So for transverse fractures, the nailing principles work the best. But when you're extending your indications to comminuted fractures or length unstable fractures, or the location of the fracture, you may have to change the nails in a way that I've put in one smaller nail, one larger nail, even though it's against the principle. I've put in nails, the tips pointing in the same direction. But I can show you several examples of the fractures healing fine, because most important thing for me is making sure that it's stable enough. Otherwise, I'll provide some external support and the reduction is acceptable. And it would not be acceptable every time following the principles unless you keep yourself restricted to the original indications. If you're going to extend the indications, you may have to modify your methods accordingly. So, just looking at the X-ray, it might be difficult to, it's easy, actually, not difficult, easy to say this is not a perfect way to treat it. But then if the result is okay, then you think that, I think some of it is based on experience as well, how you're going to be nailing it.
But that,
I think it's a good teaching point to do it, how to do it. That's a good teaching point, and we need to know the principles. But then knowingly, sometimes you would violate them.
Yeah, I think Sheetal, I completely agree, which is why even when I was asked to criticize these X-rays, I said, that I would consider them acceptable. However, the point that you made is that when you come to the unusual situation, the more communist situation, the more proximal, etc., that's where you've got to understand what the principles are. Remember, we're talking to a large audience with varying degrees of experience. And that's why it's really important to understand how it works in its basic foundation before you start to expand its indications. That's the only point. And I think what you said makes perfect sense. With respect to COVID, we would proceed. It would be in everybody's best interest to get the child, have the elastic nails in and discharge the child by, usually they stay for a day or two after, so that they can minimize their exposure to other patients and staff in the hospital. So rather than treating them non-operatively, we would probably treat them operatively so that they can go home as quickly as possible. But we follow exactly the same precautions that Sheetal talked about. I don't think there's much of a risk, nor has it been shown from body fluids other than aerosols and the from intubating and so on, but blood and bone, I don't think that's been of much concern. But we have the same precautions that Sheetal talked about.
So, the protocol at our hospital was, allowing only life-threatening surgery or limb-threatening surgery to be operated. So we put this child in a Thomas splint, sent her home. And after 3 weeks, this child was put in a single leg spica. She could walk on it. And, so she could be taken care of. Now the fracture was well aligned, well healed. And A single leg spica following a traction in a Thomas's splint allowed us to manage this child on an OPD basis at home, to be cared for and avoid risk to everyone else around. So the whole idea is you have to manage the principles. Sometimes, the age groups may be different, the geography is different, the social circumstances are different, but as long as you're looking at the principles and managing them, the things may be absolutely right. We are running a little short of time, and I want to ask Sheetal that we have a whole section on elastic nail. Can we skip that, because we are going to cover it again next week in Dr. Slongo's oration? So then we can go to more challenging cases for the audience. I'm going to skip some of the slides which are here, because some of these principles have already been spoken about. I will share these slides for the audience on the email and the group, so that they can still see these cases, but we are skipping these in interest of the time. So coming back to length unstable fractures, Sukalyan, you want to talk about this patient? Please tell us, and we go to the audience for the poll. 8-year-old child with a fracture which has a long butterfly. How do you manage?
Hey, Tarun, can you hear me, Tarun?
Yeah, tell me. Yeah, I'm hearing you.
No, I'm just saying that we have finished the time. I'm going to be here. I don't have anything else for now. But for the faculty, I really appreciate Ben's and Uni's time, as well as the faculty. And if they have other commitments, I would love for them to stick, to stay here and comment on the cases. But I understand if they have other, commitments, and if they have to leave, I really appreciate them being part of this webinar. So if there is a reason for them to leave, that's fine. But if they can stay, then we'll just go ahead with the cases. Thank you.
I can stay, no problem.
I have 10 minutes, Sheetal. Thank you. No problem.
Okay. Thank you.
Okay, so that was what was done. Audience has posed 10 plus external fixator was 48%, hip spaca 1%, traction 4%, only titanium elastic nailing was 17%, and plate was 30%. So 10 plus external fixator versus plate. So the next slide. Yes. So what was done was a submuscular bridge plating. There's 2 small incisions in the proximal part and the distal part, while the whole fracture side was spanned in the proximal, and distal. And weight bearing was painless at the end of 7 weeks, and good callus forming. Implant removal at 8 months. As the picture, which is 16 months post-op, 8 months after implant removal. Good range of movement, no limb length, as you can see. Over to Kailash, I guess.
Did you remove the plate?
Yes, of course. The last one was 8 months after the 8 months after the fracture union. We removed it early so that we did not have to struggle in removing the plate. Yeah.
So Sheetal, have you seen valgus deformity or lengthening after plating?
It's a very institutional thing how these things are treated here. We do nails for most of our femur fracture. I have seen, we have 2 partners who are doing plates lately, and I've seen one case about a valgus, and I think Ben Ben has more experience about it, but I think it may be the tethering of the periosteum. I've not seen lengthening after plating, but I've seen valgus, what they have written about. I don't know if it's a tether on the periosteum on the outside, and maybe removing the plate might help to avoid the problem.
I must say, we did not unearth the etiology of the phenomenon through the study results or the data. I think Dan's theory is that distal flare acts as almost a guide for the continued growth, and so it's so rigid that as the new bone forms, above the physis. It sort of follows the path of the plate almost. It may be a differential hyperemia on the side of the, of the plate. And, so a variety of theories we sort of bounced around, but couldn't clearly, distinguish. I will say that particular fracture, Dr. Day, might have given you a chance to be more than 2 centimeters above the physis and potentially pursue plate retention. Though I agree, if you're going to consider taking it out, it is best to do it within a year, because there's another study we have that shows that the removal of plate, submuscular plates in those under 10 can sometimes be a larger surgery than the plate fixation procedure itself. So definitely make your decision early.
Going on to the next case, this is a 6-year-old child presented with a shaft of femur fracture. As you can clearly see in the X-ray, it was a length unstable fracture. So we proceeded with a hybrid fixation in the form of a tense nail along with an external fixator apparatus, as we can see here. This is a JES fixator which is developed by Professor Joshi. Under the 3 weeks postoperative period, when we could see the good amount of callus, we removed the external fixator and mobilized the patient. This patient went on to heal without any complications whatsoever. And at around 6 months post-op period, we plan to remove the nail, and the child healed very well. This was the example of a length unstable fracture treated with a hybrid fixation of tense nail along with an external fixator apparatus.
This has an advantage and a disadvantage. The advantage is that you don't require a big surgery for implant removal. But the disadvantage is that when you put an external fixator with a nail, the knee range of movement does take a little longer time to come through. And so you have to balance on both the sides, one on one side or the other. The combination of elastic nail with external fixator is cheaper as a cost rather than putting a plate. So these are different ways of managing the same fracture. And as far as proximal femur fractures are concerned, again, elastic nails only showed a very good way, but if it's not done properly, even if it's combined with an external sort of a support, you can have varus and it can go for a problem. So Alaric, you want to show these cases where actually you opted for plating and a rigid fixation for these patients.
Yeah, so as all the previous faculty have outlined, I think there's no one size fits all, and you have to tailor your needs according to what the fracture configuration is, what the patient's and parents' requirements are, and what is your own expertise. So I think that's an important message that all our delegates should go away with. So here we have understood that when it's a proximal femoral fracture, it's so much more difficult to control because of the muscle forces on the proximal fragment. And a spica sometimes is a good option, but very often in these older patients, in fact, plating might be even better. So here we have used the Synthes proximal femoral plate, and it heals extremely well. Of course, we understand that sometimes we work in situations where we don't always have the necessary implants, or the child may be too young. And we know that in India, we don't have the facility of having the smaller size Synthes plate. In India, I think most of our Indians are aware of the term called jogad. It's actually a word which has been accepted in the Oxford English Dictionary, just like bungalow and khaki. And it basically means a flexible approach, because we're talking of flexible nails here. So it's a flexible approach to solve a problem using limited resources in a very innovative way. And what we've done here is to take a 1/3 tubular plate and to bend it like a blade plate and to insert into the proximal femur and fix it to the distal fragment. So I think various solutions can be innovated depending upon your setup, the cost involved, the patient's and family requirements, and sometimes thinking out of the box and being flexible not only with your nails but also with your thought is very useful for femoral fractures. Thank you.
So thanks, Alaric. Swapnil, you want to talk quickly about your femoral fracture in the distal femur? Unni said it's a difficult problem. And we are not having audience poll, but you can just show us what was done.
Yeah, so this is an 8-year-old who had a fall, basically, and it's really a middle third, lower third shaft going into the metaphysis. Now, length, deformity, and stability are important. What is also important is you need to basically think on the table. So this is a case where we decided to go in for a nail which we passed from below, because I was quite certain that I had a good fixation here. The rotation was a bit of an issue. We used the JES system here, and this went on to heal very well. So the fixator was removed at about 7 weeks, and eventually this went on to heal. There was no problem with knee range. I don't have the picture here, but the patient had a good knee range. The next is a case of a distal femur fracture, again with a tibia. Is this the...
No. So I've skipped those slides. So this is the pathological fracture.
Okay.
And Ben, I want to comment on this. This is 10-year-old child with non-ossifying fibroma and a pathological fracture. And this was treated with a plate and grafting. And what do you feel would be issues, about the plate being there?
Yeah, I think this is an ideal indication for a plate. It looks like it was well done. That's a distal femoral plate designed to potentially be a little bit more distal, in a larger patient. But this fixation looks reasonable. Those are locking screws, or at least some subset are locking screws. But if you go back one slide, I'll just look at the position of the plate relative to the FICS. Yeah, so you're just about 2 centimeters of plate position. I bet that hips to ankles at that time is aligned reasonably. And then with continued growth, yeah, it looks like 1.5 years. So given his age, you might have taken that plate out and not seen this phenomenon. But I think the biggest takeaway of our study would be, to monitor these kids. So you can catch this, even in the case of plate retention, and correct it. So you want to catch it before it's severe or extreme valgus. But if you follow our principles, that plate would have come out a little sooner.
So, we really couldn't remove the implant because the pathology was still healing up and we were not very confident. So what we did was growth modulation, and we corrected the deformity. But, one more issue of plating of distal femur in children is obvious here. And you can see here, the screws which were in the metaphysis, they move into the shaft as the child grows. And screws which were not prominent, they start becoming prominent. So you can see here that the same child, as the child grows, this will not happen in an adult. The screws move, which were metaphyseal and right length, move into the diaphysis, and they suddenly become longer and start hurting on the medial side. And we had to remove those screws in this child along with the 8 plate. So child always comes with surprises, things which don't happen in adult will happen in children. This is a challenge again in neuromuscular children with CP, meningomyelocele. And I want to ask Unni, what would be your choice of managing? Because they have narrow canals, poor bone stock. One treatment will not help. So Unni, I want you to, comment on this. How would you manage this patient?
Sure. I think that, this suggests that this has been a long-standing dislocation, and it's very well reported that in these non-amputee kids with dislocations, there's a higher rate of these insufficiency fractures through the femur. Usually it's more distal, but the shaft fractures are possible during the course of caregiving because they've got fixed contractures and so on. So your priority is to fix the fracture first. And I would say that it depends on, in this particular one, it is a narrow canal. I wouldn't hesitate to, now this is a child with myelomeningocele, is it?
Yeah.
Okay, so all right, so this is not a kid with cerebral palsy, but nevertheless, so it's unlikely that they've had pain with their hips, but nevertheless, you've got to treat the fracture. And I'd like to look at what that canal size is, and I think this would be very manageable with either a narrow elastic nail or some sort of we've got lots of rigid nailing systems that are not the conventional ones that we use for things like osteogenesis imperfecta, like the fascia duval. We've got the Williams rod, etc. So there are a variety of options that we have because this canal is pretty narrow. So we have to determine what that size is before we can make a determination. We don't have, it is important for nursing issues to get this to heal, for skin issues and caregiving and so on, not so much for pain. And once that's healed, it's fine.
So it has to be a rigid fixation. Ben, you have anything to add to what Unni said about these patients? How would you manage this?
No, I think Uni really, explained the principles quite well, and I would follow the same path. I was just writing a chat to thank you all. I do have to excuse myself at this stage. I can't thank Sheetal and Taral and the staff enough, and for this opportunity and the collaboration. Have a wonderful weekend. Thank you.
Thanks, Ben.
Bye, Ben. Nice to see you.
Jayant, you manage a lot of children with CP. So, they have a lot of overriding. How easy is to manage these patients? What are the difficulties you face? Jayant Sampat?
Yeah, I have managed a few of these. And they heal up very quickly. They throw a lot of callus. And really in these non-walking children, all these issues of length, alignment, stability, they really don't matter. So you don't need anatomical reduction. So I have managed many of these in just acceptable clinical alignment, and then tended to get away with it because they throw a lot of callus, particularly the myelocele. So I think you need to just manage it according to whatever the clinical situation is. And many of them are poor anesthetic risks. So doing lengthy invasive surgery, I don't think is always the right option. You need to think carefully about these cases.
Right. And they have very poor bone stock. So, even if you put a plate, these screws had very poor hold on the bone. So, just plating is not a good option. The canal diameter is narrow. So, you can't have good sized nails inside. So, we decided to have a hybrid fixation. This was actually treated by Sandeep Vaidya in our institution. And, we could manage to hold on, and finally this fracture united. Another, tricky situation in children, fracture shaft femur with fracture neck femur. So this is case from Dr. Rajiv Nirwane, and this was managed by elastic nails with Misa-nail technique and separate fixation for the fracture neck femur with the screws, and this also healed up. So, different situations, tricky situations require tricky sort of a solution. So with this, I want to hand over to Sheetal to talk to us more about adolescent femur fractures, because it's a different ball game altogether. Sheetal, over to you. I'm showing your slides.
Yeah. So before we move on to the adolescent fracture, just a couple of points. Both of them showed a distal femur fracture, which was treated with elastic nail and an X-fix on top of it. One other option which I have done for these distal fractures is to come from the greater trochanter. In both these fractures for distal femur, the entry point was it was a retrograde nailing. So I found the antegrade nailing to be better, and I've even gone further through the distal femoral crisis on both sides. And so you have a Landy segment for purchase, and I've not had issues with any growth arrest or growth disturbances. But we do tend to remove the nails, once the fracture is healed around, 6 months time. So it's just another option of treating that fracture where you had, a length unstable distal shaft fracture. Antegrade nail sometimes is very difficult. The retrograde nailing is sometimes difficult because you will fall into the fracture site as you're trying to insert it. So just one option. And then just a comment, and maybe I can get Uni's comment as well on Sandeep's case where you had the myelo kid and you have a plate on. So, for the OI, we know that we don't plate these fractures because you have a stress riser, you have, issues with for the fractures. Do you have the same things with the myelo? I don't know what was the follow-up on that patient, but I would be concerned with I know that there is a nail in there, which is great, but would you remove that plate, or would you even consider plating a fracture like that?
Are you asking me, Sheetal?
Yeah, I'm just asking your opinion on the myelo kid.
That previous case, her bone stock was actually pretty good. I completely agree with what Jan said. It's just a question of getting it healed. If it was a child with CP, because of tone issues, and there will be pain, it's an issue of keeping it stable enough that caregiving and comfort is well taken care of during that healing process. Like I said, usually the fracture is an incomplete insufficiency fracture, the distal femur. Those can be managed just in a knee mobilizer or a posterior splint for a relatively short period of time so that you don't contribute further to the osteopenia. Whereas this case, when I realized that it was actually a myelomeningocele, I would agree with you. Pain is not going to be typically an issue. You want this to heal, and I would say, even if you could get one rod up that narrow mesenteric canal, there'll be sufficient stability there. It doesn't have to be rock solid for it to be reasonably lined up and to heal. I'm not a big fan of plating in osteopenic bone, but sometimes that's necessary.
Okay, great. So we'll move on to the adolescent fracture here. So there are different ways of managing this fracture. We won't do a poll, but a trochanteric entry nail. We heard Ben's talk that piriformis nail has an issue with AVN, so it's better to use a trochanteric starting point. So here is the solid nail graded trochanteric entry point. And one tip, actually there are a few tips. One is that, when you're putting this nail, and if you have trouble getting that fragment down, the proximal fragment is flexed, you can just extend the incision a little bit. Your insertion incision, you can extend it and get a hold of the proximal fragment. It's open reduction. But what you don't want to do is start beaming with that fragment flexed, because then you would put the nail in and the fragment would still be flexed. So don't think that your rigid nail is going to be able to reduce this fracture. It would not. You need to have a reduction before you ream and before you pass a solid nail. So my recommendation would be to either you get a close reduction, or if you can't get a close reduction, you just extend and open it and then nail it so you can get a proper reduction on these fractures. Otherwise, the proximal fragment would stay flexed. Taral was mentioning when we were talking that they only have one set of lateral entry trochanteric nail for the entire country. And so that's an issue. And we had a similar issue. We went through a whole phase before we got the lateral trochanteric entry nails, and we were using the tibial nails for the femur. So this was reported from our institution, is to use the tibial nail for the femoral shaft fractures in large adolescents with open femoral physis. So if you don't have the lateral trochanteric entry nail, there are ways to improvise. One is the use of the tibial nail. The second is the use of using the humeral nails for the femur when they didn't have the lateral entry trochanteric nails. So you can read these techniques, and I'm sure the tibial nail would be available everywhere, or the humeral nail, and we have used it successfully. So that's just an option I wanted to throw out there for those who may consider rigid nailing.
Some Jugaad in Cincinnati.
Yes, Jugaad, exactly. That's what Alaric said. All right, Taral.
A different way to manage. So this was managed. We did not have a lateral entry nail. It's a length unstable fracture. There is a butterfly which is almost threatening to fly off, and in this case, again, this can be managed with a lateral entry nail. But a similar fracture can also be managed with a hybrid fixation when you put elastic nails and use a plate to interlock. So the places where fancy implants are not available, the similar principles can still be managed, by changing the methods of fixation, which we call it as Jugaad. So with this, I'm going to end the cases. Thanks everybody for joining in for the cases, and then we'll hand over to Premal for the questions which the audience has.
Taral, I think we have answered most of the questions, I guess. But I'll just go through the presentation. I'll just see, because I think most of the questions have been covered and we are already running a bit late. So I'll just go through the questions and we'll have few. So I think very early on, somebody had asked what is the earliest cutoff age for application of hip spica in femur. Kailash has asked. You want to answer, Unni? Earliest?
Yeah, I think, again, I think Ben answered that question. A Pavlik harness works very well in the child that's 6 months old or under. That's typically when they're about 6 kilograms, 7 kilograms, 8 kilograms at the most, and under. Anything above that, you need perhaps something a little bit more stabilizing. Remember, the Pavlik harness, again, it just sort of keeps the limb at rest in a better position. It doesn't really, stabilize it like a cast will. So there may be some circumstances. So you just have to, and if you don't have a Pavlik harness, then you may want to use some form of a cast. But I'm not sure you need a spiker cast. You really just need to get it reasonably lined up. And there are many examples, I think Ulrich showed, or perhaps was thorough, where that leg was flexed and abducted for a while. Within a week, there's abundant, there's callus forming, and then you can let them go. Most of these will remodel. You don't have to worry.
There was a very nice question that we were taught that there is a different level of rotation and flexion you keep for different level of practice, like upper third, middle third, lower third, as far as the hip spiker application is concerned. So what are your rules? How much do you flex and rotate for each level of the femoral shaft fracture in spiker treatment?
Right. So I think that for diaphyseal fractures, our preference is, because we want them to be, we use single spiker casts. We keep the knee flexed somewhere about 70 to 80 degrees so they can sit comfortably in a stroller. And the hip is flexed about 45 to 50 degrees so that when they lie down, the heel is at the level of the bottom. So that's the typical configuration. And it's about 15 or so degrees of external rotation to match that proximal segment. And we check with the X-ray AP distally and proximally to make sure that they're both AP views of the hip and the knee respectively. The more proximal you get, that proximal fragment is more flexed, abducted, and externally rotated. The more you need to flex up your hip. So it really is a dose response. And I would say that in a very flexed and abducted externally rotated fragment for a subtrochanteric fracture, for example, then what I first described, that's not enough. You really have to flex up quite a bit more. That's closer to about maybe 80 degrees or even up to 90 degrees of flexion of the hip.
So go ahead and answer one more question, Uni. Very nice question by Juan, that how do you deal with the parents and relatives of the patient whom you suspect of having fracture secondary to anything? Because we don't see that often in our setup. So what are your guidelines and what is your experience?
I think this is a very good question. Now, while it is absolutely incumbent on us to think about this when a child who is not independently ambulant comes in with a femur fracture or any other injury, it is important also to recognize that sometimes there is a genuine explanation. So please don't be judgmental. What we do is we say to parents, your child has this particular injury. This is part of our protocol. Every child with this particular type of injury, we are compelled to do an investigation where we ask you questions, because sometimes this can be due to, it is, and it may not be the parents, it could be somebody else. So we just explain to them that it is in the child's best interest for us to ask them all these questions. And that way we are preparing them and also being sensitive to the possibility that those parents may be perfectly innocent. And it does not in any way undermine our ability to find out by repeated questions, etc. So we will always introduce them to the idea that this is part of a process and that they're a separate team whose expertise is this area. And we just tell them, please answer the questions. This is why we do it.
So that was very well answered, Uni. I think we had a very exhaustive session, and I think we also tomorrow have a long session. So I think we'll excuse our delegates to enjoy whatever little Saturday has remained. So we had a wonderful session. So I thank all the faculties and panelists, as well as delegates who have shown great interest in IFICS and making it a great success. Thank you very much. Unni and Sheetal, have a nice day, and rest of the delegates, maybe good night, and somebody in other corners of the world, different time, maybe good morning for them. Thank you very much.
Thank you, Premal. Thank you, everybody. I really enjoyed that. Thank you so much for the opportunity.
Thank you, everyone.
Absolutely. And also, thank Dr. Chandak and Dr. Negi for being here as trauma surgeons. And we have lots of cases, and maybe Ben could write another book, but a lot of cases I could not include on this session, but we will have them on as the IFICS proceeds. So come tomorrow again. Let's check in at 6:15 p.m. for a very interesting session on fracture neck, femur, and ankle and foot injuries in children. So that's tomorrow, Sunday.